Good morning, everyone. Good morning, everyone. Everyone is requested to kindly assemble in the auditorium. We will be starting with the session. Please wrap up your breakfast in the next 5-10 minutes so we can start. Good morning, everyone. Everyone is requested to please assemble in the auditorium so we can start with the session. Please wrap up your breakfast in the next 5-10 minutes so we can start. Gentle reminder to everyone to please assemble in the auditorium. Good morning, everyone. Everyone is requested to please assemble in the auditorium so that we can start with the session. Please wrap up your breakfast in the next 5 minutes. Gentle reminder to everyone to please assemble in the auditorium. We are waiting to start the session.
Hello, mic check. Hello, 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 check, check, mic check. Hello, hello. Hello, check. Hello, mic check. Hello, 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 mic check. Hello, hello. थोड़ा और बढ़िए हेलो हेलो साउंड चेक हेलो 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 ओके
Good morning, everyone. We are waiting in the auditorium to start the session. Kindly assemble in the auditorium. Gentle reminder.
अभी बंद बंद करना ऐसे हेलो चेक हेलो चेक हेलो 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 वन टू हेलो माई टेस्टिंग हेलो हेलो चेक हेलो चेक हेलो माई टेस्टिंग हेलो वन टू थ्री हेलो चेक ओके
में वार्षिक लाख रोगियों के उपचार के लिए 710 बेड का प्रबंध होगा। 25 आधुनिक मॉड्यूलर ऑपरेशन थिएटर से लैस एनसीआई देश का पहला सरकारी अस्पताल है, जिसमें लीनियर एक्सेलरेटर के अलावा प्रोटॉन चिकित्सा की भी सुविधा होगी। यहाँ 15 करोड़ की लागत से पूर्ण रोबोटिक लैब स्थापित की गई है, जिसमें प्रतिदिन 60,000 से अधिक टेस्ट किए जा सकते हैं। भारत सरकार की डिजिटल इंडिया पहल के तहत पेपरलेस क्रिटिकल केयर सिस्टम एवं ओटी इंटीग्रेशन की सुविधा भी स्थापित की गई है। एनसीआई में 700 करोड़ से अधिक के आधुनिक चिकित्सा उपकरण स्थापित किए जा रहे हैं, जिनके माध्यम से व्यापक कैंसर चिकित्सा, शिक्षा एवं अनुसंधान किया जाएगा। एम्स नई दिल्ली का राष्ट्रीय कैंसर संस्थान झज्जर भारत का सबसे बड़ा कैंसर चिकित्सा, शिक्षा एवं अनुसंधान केंद्र है। एनसीआई में वार्षिक 5 लाख रोगियों के उपचार के लिए 710 बेड का प्रबंध होगा। 25 आधुनिक मॉड्यूलर ऑपरेशन थिएटर से लैस एनसीआई देश का पहला सरकारी अस्पताल है, जिसमें लीनियर एक्सेलरेटर के अलावा प्रोटॉन चिकित्सा की भी सुविधा होगी। यहाँ 15 करोड़ की लागत से पूर्ण रोबोटिक लैब स्थापित की गई है, जिसमें प्रतिदिन 60,000 से अधिक टेस्ट किए जा सकते हैं। भारत सरकार की डिजिटल इंडिया पहल के तहत पेपरलेस क्रिटिकल केयर सिस्टम एवं ओटी इंटीग्रेशन की सुविधा भी स्थापित की गई है। एनसीआई में 700 करोड़ से अधिक के आधुनिक चिकित्सा उपकरण स्थापित किए जा रहे हैं, जिनके माध्यम से व्यापक कैंसर चिकित्सा, शिक्षा एवं अनुसंधान किया जाएगा। एम्स नई दिल्ली का राष्ट्रीय कैंसर संस्थान झज्जर भारत का सबसे बड़ा कैंसर चिकित्सा, शिक्षा एवं अनुसंधान केंद्र है। एनसीआई में वार्षिक 5 लाख रोगियों के उपचार के लिए 710 बेड का प्रबंध होगा। 25 आधुनिक मॉड्यूलर ऑपरेशन थिएटर से लैस एनसीआई देश का पहला सरकारी अस्पताल है, जिसमें लीनियर एक्सेलरेटर के अलावा प्रोटॉन चिकित्सा की भी सुविधा होगी। यहाँ 15 करोड़ की लागत से पूर्ण रोबोटिक लैब स्थापित की गई है, जिसमें प्रतिदिन 60,000 से अधिक टेस्ट किए जा सकते हैं। भारत सरकार की
A very good morning to everyone. We now begin with the third and final day of the minimally invasive thoracic surgical oncology workshop. After 2 days of heavy duty academic activities, including the cadaver workshop and the live surgery workshop, we have a relatively lighter day planned today, consisting of interactive sessions and video lectures. Without further ado, I will hand over the stage to Professor Diego Gonzalez Rivas, the chief proctor for the workshop.
Today's schedule is going to be the 1 hourly sessions. We'll have Dr. Diego first. Then we have 4 lectures, 4 to 5, followed by a free paper presentation. We are planning to finish by 11:45 or 12 o'clock. After that, we have a dry lab, both robotic and VATS models are there. So I request all the students to utilize that time. Thank you. Professor Diego.
So good morning, everyone. I want to show you a journey that started 2006 when we were dressed the VAT technique, and I was very enthusiastic about minimal invasive surgery, and then I decided to go to United States for learning minimally invasive surgery. So what means minimal invasive surgery? Minimal invasive surgery means to perform the less invasive approach to our patient. That means that if we compare what with an open approach, we can see that there are a lot of advantages, a lot of benefits because the patient has less pain, can go early with faster recovery to the daily life. So I think it's very important to think about the minimal invasive techniques nowadays. And as you can see in this film, there's no much to say. We don't need to talk too much about the benefits of minimal invasive surgery because all of us knows what means a thoracotomy for a patient. So this is why we are so excited to proceed to work on everything that can be better for the patient, like uniportal valves, for example, which is the final step of the evolution. So in 2007, I decided to go to the United States to visit Ron McKenna, who was the pioneer, who was a master at that time. And I was really impressed that everything was possible with small hole. At the beginning, I couldn't believe how it's possible to do lobectomy with the small holes. But then when I saw it, I realized that you can do everything minimal invasive, every kind of lobectomy. And then I went back to Spain. I started to perform minimal invasive surgery at that time in my hospital. I was working in a university hospital, one of the biggest in Spain, with a big volume lung transplant program. So we reached 100 cases easily. We overcome the learning curve, but I decided to go back again to the United States to learn more. This is why I went to New York, to Memorial Sloan Kettering Center, just to see this technique from other surgeons. And when I was there, I met a surgeon from Duke, and it was a resident at that time. And she told me that in Duke, North Carolina, they were using only 2 ports. For me, it was like a shock. I'm talking about 2008. Wow, how is possible 2 ports? No, impossible. You need no. And she make this drawing for me, explain me. Yes, with 2 ports you can do everything. You just move the camera from one port to another port. You have to change the instruments and everything. You can do everything. Wow, I was really impressed. And I said, I have to learn this. You know, at that time, I was sure that this was better because we know as a surgeons, we are surgeons. We know that 2 ports will be always better than 3 and 1 will be always better than 2. No, we don't need randomized controlled trials to know that doing less invasive surgery is better for them if you do properly. Then I say, I have to go to the United States. And then I contact the chief surgeon at that time, who was Thomas Amico, a big name. And then I sent an email to him. Hello, Dr. Amico, I would love to visit your hospital, blah, blah, blah. I'm a young surgeon from Spain. And then he replied me, okay, Dr. Diego, thank you for your mail, but I cannot accept surgeons I never met before. I'm sorry. So you can imagine my face. I was rejected by him. So wow, what about luck? And initially I said, okay, I don't need to do this. I will continue with my 3 parts. I'm happy. But you know, day by day I was thinking about this. I have to see this. I have to see. And you know, I never give up. And I say, we have to do it. So I decided to go to the United States to a meeting where he was speaker in the ATS. And then when he finished his lecture, I approached him and I started to talk to him. Hello, Dr. Domingo, I want to see you. I want to visit your hospital, blah, 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 blah. And he was very kind with me. I said, okay, just send me an email. Okay. I went back to Spain. I created another account, Gmail. I sent an email to him. And then he accepted. But it's a very interesting story because, you know, that means that, you know, if you want something in life, you have to fight for that. You need to be persistent, is the secret. And then I went to Duke. I saw the technique with him. It was amazing. I was really in love with this technique. I said, wow, everything is possible with 2 ports. I don't need more ports. And, you know, we start to be friends, and now we are very good friends. We do courses together. He stays in my house, I go to his house. We are very good friends. And the most important is that he is now doing an portal for half of this case. So this is life. Then went back to Spain, and then I started to do 2 ports. I was really happy when I was doing 2 ports. And then I realized that, okay, for 2 ports, when I put the camera here, I had a better view, because when I put the camera in the utility incision, I have a direct view to the hilo. So this is why I say, okay, why not keep the camera all the time here, and then I have a better view. And then I started to put everything together, together for lower lobectomies. And then one day I say, okay, let's do everything uniportal. And then in June 2010, we did the first uniportal lobectomy in the world, because we put everything together through the single incision, and everything worked very well. So we were very excited with this. We sent for publication, and it was interesting because we sent to GDCBS, and it was rejected. But the most funny thing is that the 3 reviewers who reject my paper at that time, 3 big names, are nowadays uniportal surgeons. So this is the story of medicine, the story of life. You know, every innovation is always rejected at the beginning. You know, it creates some jealousy, creates some envy. Some people, you know, when you break the status quo, people don't like. Some people, especially all minds. So, and then I sent to another publication, and it was accepted. And it's one of the most cited publications in minimal invasive surgery nowadays. And it's interesting because I was doing surgery many times in Africa. One of my visits, I went to the hospital of Chris Barnard, the surgeon who did the first cardiac transplantation. And also the team of Barnard told me that when he did the first cardiac transplantation and sent for publication, it was rejected. So you can imagine that this is the story of medicine. So when we published the technique, we thought that the technique was only feasible for lower lobectomies. And this is how we describe. If you see the publication, we cited that. Okay, this technique is only for lower lobes, because for upper lobes, we need different angles, you need different staplers. You know, at that time, thinking of going to the upper lobes through a single hole was crazy for me. You know, but now everything's clear. We started to think uniportal. We started to think different way. I started to make some schemes, how to put the staplers for the upper lobe, how to put the grasper, how to put the retractor, how to put everything. I have to change completely the technique of multiport. It was a new technique, a different technique, completely different. And then we saw that, okay, we can do everything, not only lower lobes, upper, everything. Of course, the most important is that this was a teamwork, all together. It was very difficult to work alone. You need a team, you need your assistants, you need your nurses, everyone working in the same direction. So we started to publish all the cases. First fissureless, first left upper lobe, first pneumonectomy, first segmentectomy, first results. We published the technique in different textbooks of medicine for the first time, step by step. We also published more complex cases, tumors involving the chest wall, sleeve. And then we were evolving to do more and more difficult cases, and we saw that there were no limits. We can do a lot of innovations with uniportal, subxiphoid, no intubated, everything. So we published our experience, very important, in the annals, with good results. We reported survival for the first time in oncological meeting in Geneva in 2015. It was the first time that we reported our survival, because it was an important moment that the technique was not only feasible and safe, but also oncological. Very important. And then we started to see more surgeons doing uniportal with less pain, shorter recovery, and more groups publishing the experience in survival. So very important point. We show evidence and more studies showing better quality of life of Uniport. But of course, when you do something new, you have to continue improving. It's not about, okay, just do one thing, one case, and keep the same technique. No, you have to move forward. You have to do new things. You have to evolve. Of course, you need the instruments, you need the equipment. Very important. At the beginning, when we started in the portal, we used conventional instruments for almost 100 cases. But of course, we struggled, it was difficult. And then we developed the instrument with proximal and distal articulation, this one, the Scalan one. And this makes the surgery much easier, changed completely. And then we started to use, of course, powered staplers, manual staplers, the curved tip help a lot. We saw that using the curved tip staplers, we help facilitate the lobectomy in the portal much more. Energy devices, clips, everything. Of course, one of the important things that we have seen is that we need a training. We need a proper training. So that means that we started to create courses to teach other surgeons. This is why we created the Lisbon course. In Lisbon, you have a course every month with cadaver, with live surgery, and all the facilities, high definition cameras, scanning, similar setup as we have here. So this is mainly for European people, United States, and we have participants every month. We do live surgery lectures. We have a robotic center there, and I think it's very good because it's important to train and to do courses properly. It's the most important way of learning, attending these kind of courses, because when we are doing the live surgery, people learn. But after the people see how we do the live cases, they can do themselves the same maneuvers that we did during the case. So this is the best way. Replicate the maneuvers. And we also do robotic combined with Uniportal. There, we do hybrid, we do fully robotic. So there are different ways of teaching. So we have evolved in the last years. As you can see, this is the early period, 2010. We use a bigger incision, conventional instruments, and now we have evolved to a smaller incision, proximal and distal articulation, and what we call advanced instrumentation. But why is it important to change? Because if you don't change, you will lose your patients. You remember Nokia. Everybody remembers this brand. It was the biggest brand in the world. It was the brand of mobile phones that have all the technology. And where is Nokia nowadays? This company died because they didn't want to change. It's so simple. They were so powerful and they were so confident, and they say, no, we don't need this new technology. And then the new technology came, the smartphones. And they say, no, we don't. We have all the customers in the world. They were focusing on making smaller phones in size. Remember, they were making small. No, this is the future. No, the future is in this touch screen. Look, the charger screen. No. We don't need that. And then other companies like Apple, Huawei, Samsung, okay, we follow this direction. And they say, no, we don't need, we have the power. And then they started to lose the power and they died. And now it's impossible to go back to the market with the same level. So this is a clear example. In thoracic surgery is the same. If you are you can be very good in one technique, but if you don't change your technique, if you don't evolve your technique in the last years, the patients will go to another surgeon that they will remove the tumor through the lung, through the mouth, without a scar. And this is what nowadays is science fiction, but in the future will be a reality. So don't forget, because if we look back 30 years ago, and we think, okay, in 2023, you are going to do double sleeve through a 3-centimeter incision and with a robot. Say, everybody's impossible. And now we are doing. So this is why, you have to think always that the future is the change. So what are the innovations with the technique in the last years? I think we have summarized many things. We can do sleeve, complex cases, bronchoplasty, everything within important, non-intubated. But I think the most important and relevant thing is that we can teach the technique now, thanks to the high volume training course we established, for example, in Shanghai. When I started the technique in 2010, I started to be invited around the world for giving lectures about this. And everybody say the same, oh, this technique is amazing, but no future, because only Diego can do it. Because Diego is very skilled, but nobody can do it. So this technique will die. Too difficult, blah, 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 blah. I heard this at the beginning many times. And then I started to say, okay, I'm going to travel around the world to teach this technique and to show that everybody can do it. Everybody can do it. So this is why we started this volume center in Shanghai Pulmonary Hospital in 2013. I arrived there, and you can see the volume was increasing crazy. And last, in 2021, 20,000 major resections in 1 year. So, and we saw some papers where we explain how is the impact on the surgeons when they come to our training course. It's really, really amazing. So if you want to come, you just come. You can mail me directly, and I will arrange for you. This year we will restart in March, the training courses there, 2 weeks. And they are free, the course, no need to pay. So what are the things we can do within Importa? Within Importa, you can do everything. For example, in Shanghai, we have a lot of GGO, a lot of early stage lung cancer. So we can do bilateral resection, bilateral anatomic segmentectomy. It's good. In one single incision, if we do subxiphoid, or if we do uniportal in two incisions in the same patient, at the same time. Even more complex cases, like a complex anatomic segmentectomy, segment 9, segment 10. So when you have the experience, you can do everything. This was in Burkina Faso last 2 months ago. And the most interesting thing I want to show you here is that in even complex cases, we did a segmentectomy here, segment 9 and 10, and we saw abnormal variations. So you have to be always aware about the anatomic variations on the segment. This is segment 6. We split the 6 completely to remove segment 9 and 10. But this patient has a B8, B9 together, which is abnormal. It has the vein for the segment 6 coming from anterior, which is abnormal. So you have to be always aware about the anatomical variations when you do segmentation. Also, we can do tumors involving the chest wall. We can do uniportal with chest wall resection. Or in cases like this, and I think that here in India, we have a lot of cases like this, a lot of TB, a lot of aspergillomas. You can also do uniportal. Of course, you have to be very experienced. These cases are very challenging, as you know. In Africa, most of the cases are like this. Aspergillomas, everything is stuck. Destroy lung, that we can do uniportal easily. So I think uniportal provides you a very good view to do these complex cases. I'm really happy with this. Also, bronchial sleeve, as you saw yesterday, is one technique that when you learn the uniportal is fantastic. Is by manual instrumentation, replicating the same movements you do in open surgery. I think it's for sleeve, uniportal is fantastic. When we did the first sleeve, because I was doing lung transplantation for many years, so I was used to the movements. The first case we did interrupt, but of course we saw that it doesn't work for minimal invasive. You have to do running, and it's much better. And now when we do transplant, we do even running suture. And then we also for the technique of vascular reconstruction, at the beginning when we did the first cases, we used a clamp to clamp the proximal and distal artery, but we saw that it was not good. So we developed this tourniquet. I had with me yesterday ready in case we need it. And this is very good technique because you control the main PA, and then you clamp the main PA and you put the tourniquet inside the chest. So you have more space to work. You don't need to be worried about something through the incision that creates some troubles. So you put it. This is not only for vascular sleeve. This is also for vascular control. If you have a difficult hilum, you control the artery, and you are, more relaxed. You are more safe. So always, this technique is very good. I really like it. Fantastic. Different ways to control the artery. We can do sleeve on the right side or vascular sleeve on the left side. You have both possible options. We did the first double sleeve in 2014 by minimal invasive. Also for carinal resection, we can do carinal pneumonectomy, of course. Carinal right pneumonectomy. Then we join the trachea to the left main, or we can do carinal resection and reconstruction. In these cases, we use ventilation jet. This is a case that we have the trachea here, left main. We start the anastomosis first from the trachea to the left main, and then we pass the tube, and we and then when we do the first join, we have to do the join of the intermedius because we did the right upper lobe, intermedius to this neocarina. This is very important too. And then at the end, because we resect a lot of trachea here, we have to release the pericardium, put a flap of the thymus, and cover the anastomosis. For the tumors on the second carina, we can do sometimes second carinal resection. We don't need to do lung resection. Like this case, if the tumor is located on the second carinal division, and then we cut the left main, we cut the left upper, we cut the left lower, and then we join the three tubes. Also, the non-intubated technique is one of my favorite fields. I started to do non-intubate in 2014, and we did the first cases in the world in 2014 of uniportal non-intubated lobectomy. And I think it's very good because, with non-intubated, you have a lot of benefits. Of course, you have to learn the technique. You have to know everything about this technique. You have to be experienced with anesthesis, with everything coordinated, because it's not an easy technique. Okay? You need to know how to do the intercostal block, maybe sometimes paravertebral blockade is good, block the vagus nerve. So, but when you learn the technique, it's really amazing. You can see here, the patient, nobody can imagine that this patient is not intubated. You can see the collapse of the lung, it's perfect. Because it's the most physiological way of operate the lung. The lung, air goes spontaneously because it's collapsed by the pneumothorax. So I think it's a very good technique. And we also published the first cases of carinal and tracheal non-intubated. We published this in GTCVS, in the American Journal, and we published 18 cases of carinal non-intubated resections. It's really amazing. Of course, the patient is breathing, as you can see here, trachea, left main, and then we do the carinal. Of course, this is only for very, very high volume and experience center. We do in China. And then we also were very interested in develop the substiphoid. So I think people were here very interested to see the substiphoid. I can show you how we do this technique. Of course, it is very important to select the patient. Not all the patients are suitable for substiphoid lobectomy. I think substiphoid is the best approach for thymectomy. For me, no doubt. For lobectomy, it's a good approach. but with some limitation, especially on the left side. On the left side, you're going to do lobectomy. You have the heart that interferes. You have some limitations. For the lymph node dissection, is not an easy technique. So it's a good technique, but you have to select the patients. Not all the patients are suitable. Okay? And you need special instruments. For the subxiphoid lobectomy, you need a special instrument. You need longer instruments, specially designed for subxiphoid. It's very important to have this instrument. You see, the instrumentation is different. And we have another alternative, especially on the left side, which is a subcostal. If you go in the right side, you can do subxiphoid. If you go on the left side, it's better to do a little bit more lateral. It's called subcostal. And in this way, we have a better access to the chest cavity. Okay? Also important that for subxiphoid, the assistant is normally on the other side. Because the patient is semi-supine or in the lateral decubitus position. I'm talking about anatomic resections. Okay? Also important to remove the xiphoid process. So you need to identify the size of xiphoid process and cut it. This is painless. No, there's no pain for this. But you create more space when you cut the xiphoid process because it's cartilaginous. Increase the space. So I think it's important. And with the finger, it's also important. When you cut it, with the finger, you can put the finger and create a space. Also important. So one of the benefits of the subxiphoid is to do bilateral resections. With the subxiphoid, you can do bilateral. For example, this patient has a right cancer, right upper lobe cancer, and then you can approach both sides, which is amazing because one incision, bilateral resection. For example, you open the pleura. It's very important to use these instruments. This is the view we have. So you can see that the lower lobe is normally deeply located, so not easy. But for example, here we do just the right upper lobectomy, and then we go to the left side and we do just a wedge because it was a single lesion on the left side. So we do one incision and two resections, lobectomy and wedge. We can do also segmentectomy. Another good indication is if we have, for example, a lung cancer and thymoma. So it's perfect. We can do lobectomy and we can do thymectomy. So it's important to open the space correctly, open the pleura. Be careful always with the phrenic nerve, but the phrenic nerve is normally deeply located. You see the instruments are longer, longer instruments are angulated. And you have to be sure that you have a different idea, a different view with the subsequent lobectomy. The staplers also it's useful to be longer. So you do lobectomy. The angles are a little bit more difficult. For example, for me, the lobe is good. For right lower lobe or left side, I don't like very much. But when we finish the lobectomy, the most difficult part is the lymphadenectomy. When we finish the lobectomy, we can do the thymectomy. You can see. You see the denominate here with some thymic veins. So the view we have for the thymus is the best because we approach from lower and we see both phrenic nerves. So we control both sides perfectly. So we can do a radical thymectomy from bottom to top completely and remove upper, lower poles easily. So this is why I really love the subxiphoid for thymectomy. It's fantastic. Also for big thymus, we can also do subxiphoid non-intubated lobectomy, subxiphoid non-intubated thymectomy. Of course, it's also possible. You have to be experienced with your team. Very important. For thymectomy, I think is the best technique, no doubt. You can see how radical you can do the thymectomy. It's the most radical approach, more radical from the left and from the right. Subsequent is the most radical approach. Especially if you have this retractor to elevate the sternum. Okay, you elevate the sternum and it's easy. If you don't have this, you can always do retraction with a Langeweber or something. Okay, you can put here like a bar and Langeweber and fix it. There are many ways. Okay, or the assistant doing traction. It's another option, but it's important to elevate the sternum. Another option is to use the CO2. You can use CO2 and increase the, but you have to put a globe. I will show you later. We have also possibilities to do uniportal transcervical lobectomy through the neck. But this is in Poland. We did with Marcin Zielinski. Not, for me, it's not the best approach. But, you know, Marcin Zielinski is very experienced with this technique. He liked it. We did when I was in his hospital. We did the first case purely uniportal. Because normally he used 1 incision plus 2. Not, but it's possible, just to show you that you can do lobectomies through the neck. And the advanced instrumentation. I think yesterday you showed how we do this advanced instrumentation. With the left hand, we use the suction, and with the right hand, we use energy device, either harmonic, ligature, whatever. You saw in the second case, we use a ligature. You can use both. And it's very good because one of the concepts of uniportal is to avoid the use of many instruments, to make it simple, you know, smooth. This is the evolution. Develop the movements to make everything simple, no compression in the intercostal space, you know, everything simple. But what is the next step? We have to evolve. There are systems now of 3D naked glasses. This system recognizes my eyes and we create like a hologram. So it's very interesting. Or the technique we develop also is called unisurgeon. That means that the surgeons do everything alone. I have some publications with this, and we did like 50 cases. When I was in Shanghai, I was trying to develop this technique alone, with no assistant. With the voice, this is with the feet control, the camera, or this is with the voice control. I say right, left, up, and I control the camera with my voice. So I don't need assistant. I do everything alone with no assistant, which is one of the good things that is very interesting. And then why we develop this, why we think about this? Because, you know, now they are working on these wireless cameras with no cables. So you put the camera inside the chest and then you move from, you know, from with remote control. I think it's very interesting. Wireless system. So you put the camera inside. This is the future. So no need to put the camera through the incision. You have more space to work because the more space you have, better instrumentation. And if the camera is inside, you have different angles from outside. This is one thing that is under development, but this is my prototype. I developed this in Shanghai. This is a wireless magnetic grasp. I put the camera, the magnetic grasper inside, and we move from outside with magnets. So it's very good because we put the camera inside, we put the magnet inside, and then we have a small incision. We don't need to put a bigger incision. So this is something that I was developing this is my prototype, but the pandemic came, so I hope we will start now again. But then robotic surgery started to be more and more popular. And it was very interesting because, okay, all the surgeons say, okay, why you, the robotic surgery is better instrumentation, better lymph node dissection, visualization. Yes, I always agree with this. If you like tech talk, I have a tech talk on 2013. It's online. You can see on YouTube. Where in my lecture in 2013, in one of my slides, I say that the future is uniportal robotics. I say that in 2013. I always agree that the future will be robotics, but it takes time, needs time. And this is why in the last years, I didn't went into robotics, because you need 4 to 5 incisions to do a robotic lobectomy. So why should I use 5 holes, more expensive, if I can do it with a single incision, cheaper? This was always my, and the results are very good with Uniport. I cannot do 5 holes. I can't, because it's not ethic for me. For me, because I'm doing Uniport and I'm expert in Uniport. And then in 2016, I developed this idea, the single port robot with intuitive. And then I say, okay, let's develop this kind of robot. And all the team came to Shanghai, stay with me in Shanghai for 10 days. And then we started to develop this platform, the single port robot. And then we did the first cases in the world in 2016, 18. We went to Sunnyvale in the United States. In the cadaver lab, we did the first cases of single port robotic lobectomies with this device, with the SP, the single port platform. The problem was that, when you use the single port platform, you need to do subxiphoid, because there's no way, because it's too thick for the transthoracic, this device. It's 2.5, so you cannot put through the chest. And the other problem is we don't have staplers. So the access through the subxiphoid is not easy. It's not for every surgeon. This device is good for thymectomy, but for lobectomy, still need a long time. This is why it was not totally comfortable. And we have a trial ready in Shanghai in 2020, but the pandemic stopped the project. So this is why during the pandemic, I was locked down at home in La Coruña. I was traveling and then suddenly locked down. And it was good for me because I had time for thinking. I have 2 weeks doing nothing at home, relaxed, what was a strength for me. During the lockdown, I was like in shock because I was in Africa doing masterclass. I stopped in Spain just for 1 week and go to Shanghai, and then the pandemic lockdown and till now. So you can imagine how everything changed for me. But it was good because during the pandemic, I was at home, stuck. I have free time for thinking. Wow. And I had the Da Vinci Xi in my institution. I have a private hospital where I work there for many years, and we have the Da Vinci Xi. And I always saw it when I was doing surgeries. But I say, I don't need this because 4 holes. No, I can't. During years. But then during the pandemic, I started to think, okay, why not use it with maybe 2 holes or 1 hole? I think it's possible. I started to think in my mind, change the configuration, think about this, and then we did the first case with 2 ports. So in 2020, I decided to say, okay, let's do the first case in first lobectomy, use only 2 ports. So what I did, I put the camera here and the instruments down. I canceled 1 arm, and I saw that it was okay. You can do lobectomies with 2 ports with the robot. You don't need to use all arms. And this technique is very good, very easy to do with 2 ports. Of course, at the beginning, I was using similar concept as VATS, like advanced instrumentation with the suction. But of course, in robotics, you have to change the technique. It's different. You have to do a robotic technique with the Maryland coagulation. It's different. You cannot use the suction. Robotic suction is not useful. So I did 3 cases like this, and it was too much for me. No, too invasive. I have to do something else. So I started to think about why not fully robotic uniportal. Then I started to think again, do the adjustment in the arms. I think I can do uniportal. And then in September 2021, we did the first fully robotic uniportal lobectomy in the world, in Spain. Of course, when you do fully robotic, you need to put the incision lower at the 7th intercostal space. So you cannot go like uniportal, 5th intercostal space. You can't, because you cannot angulate the staplers. So you need to go lower, to be able to angulate the staplers inside. Very important. And we saw that, okay, of course, we saw some difficulties at the beginning. We struggled until we are developing completely the technique. It was really interesting. I started to travel, and we saw that we can do also this technique hybrid. Hybrid means that the assistant put the staplers through the incision. This was made by Chinese before. They did some hybrid few rats, but it's not good because they cross the arms and they put the staplers through the incision. I think that the robotic should be fully robotic. The surgeon should control everything from the console, because that makes sense to the robotic surgeon, okay? Of course, the most important is to do a good control of the arms, see? The docking is very important. I think when you learn, the docking of the robot is very quick with uniportal. This is why I'm so happy with this technique, to make a good docking and not wasting time with the uniportal rod. We started to publish our experience. We did the first publication of full robotic technique in the literature. And then recently, I have been the guest editor of the Annals of Cardiothoracic Surgery. And we already published this special issue in January with many publications, many papers. And now in March, this month, is going to come the second part with many more papers. So we are very happy about this. So we have evidence now. So we have to also consider a correct placement of the arms. This is one of the most important things. And this is why on the right side, we cancel the arm 1, and on the left side, we cancel the arm 4. And you need to adjust. If you read the publications, you can see. So what are the advantages of uniportal rats? It's cheaper because we use only 3 instruments. We don't use 4, we use 3 instruments. So we save money of 1 instrument. The docking is quick, it's less painful because it's single incision. So there are many advantages of uniportal robotics. Of course, and with the technology coming, 8mm staplers with trocars, everything is easier. Of course, there are some disadvantages. It's more demanding technique. Okay, one of the things that is important to consider in the uniportal rats is that you need a good assistant. For example, in multiportal rats, you don't need a good assistant. You can do with a nurse alone. But in uniportal rats, the assistant is very important. So you have to work together. He has to know how to put the instruments to the incision, to retract. He needs to know how to adjust the arms to avoid collision. So a lot of small details. And you need special trocars. Okay, these are my customized trocars. I customized this. They are from original. I removed 1 piece lateral. And the good thing is that with these 3 trocars are narrow, are thinner, you can do much easier. So I think it's a very good way of doing the robotic report. One of the good things is the robotic approach is better for the complex cases, have better view. Lymphadenectomy is quite good with the uniportal rats. I cannot say this better than uniportal rats because it depends on the surgeon. I think the lymphadenectomy depends on every surgeon. If you are good in lymphadenectomy, you can do good with uniportal rats, open, multiportal, whatever. If you are bad, you will do always bad. So maybe the robot helps a little bit to go deeper and deeper. But the robot helps a little bit, but I think it depends on the system. But of course, with uniportal, you can do a very radical lymphadenectomy. For segmentectomy also is very good. It's a very good tool, the robot. You can do complex segmentectomies. One of the benefits of the robot is that you can use indocyanine green, and you delimitate the intersegmental plane very well. I think it's a very good technique. The robotic platform. So there are a lot of instruments that are very precise. For pneumonectomy, also the robot is good because in uniportal, when you do a left pneumonectomy, you have to go through to fifth. And even going to fifth, the angle for the stapler for the bronchus is difficult because, as we know, in pneumonectomy, you have to have a short stamp of the bronchus. But the good thing of uniportal that because we go in the 6 or 7, the angulation for the stapler is easier for the bronchus, you see? So it's easy to place the stapler for the bronchus. And for the sleeve is the best. Okay, for the sleeve is the best because we can do the anastomosis easier with the robot. I think this is the technique we use in bats. We tie outside, we need a knot pusher. In robotic is different. We tie inside, the intra-thoracic tying. And you can do every kind of a sleeve with the robot, all kind of sleeves. You can do upper lobe, lower lobe. For example, when we do left upper sleeve, I wanted to show you yesterday, but unfortunately the case was not suitable. But when we do the sleeve on the left upper, we always do this trick. You know, we fix the artery with a tape, we fix to the pleura, and we retract the artery posteriorly. So this is why I think the robot is very useful for kind of case. In vascular reconstruction, we have different options. We can do the vascular reconstruction with tourniquets, or we can do with bulldog clamps. For example, if we use the tourniquets, we need to do, this is a left upper double sleeve. So we need to do the lobectomy, remove the robot, put the tourniquets with bats, because the tourniquets are very dangerous with the robot. You need to fix it strongly, and then put the robot to do the double sleeve. This is we always in double sleeve we do the bronchus first, and when we finish the bronchus, we do the artery. The artery is much more difficult because we need the diamond needle holder. Because if you use 5-0 with a normal needle holder, it breaks easily. So you need a diamond needle holder, more difficult. So, and this patient, you can see that is walking 24 hours after the operation, 24 hours after double sleeve, walking. So I think it's a very good technique with no pain, very good. If you do fully robotic, we can use the bulldog clamps, like this case. So we put the bulldog clamps, and we so we don't need to remove the robot for this. We do put the bulldog clamps, we do the artery, and finally we do the bronchus. The same, running suture, and it's very useful. For thymectomy, we can use the XI uniportal, but it's difficult. It's difficult. I tried. I did a couple of cases, but I don't like. I am not comfortable. So what we did was to develop this technique a little bit modified. Okay, and then we do subxiphoid plus 8mm incision on the right side. And we use a globe here for the CO2. So with a globe, we can use the CO2 insufflation, and then we can have a better exposure for the thymectomy. Okay, very important. And you can see we could do a very radical thymectomy. For aspergilloma, I think one of the benefits that the uniportal is suitable. If you have aspergilloma, everything is stuck, it's almost impossible with multiportal because robotic. Because you need to create the space. I mean, you cannot put the robot, you cannot dock the robot unless you detach all the chest. So, because we work in parallel, is one of the good things of the robot. You can work, in parallel through a single hole, and then we we can do everything easily. Also, you can do non-intubated. We did the first case in the world of non-intubated robotic. We did in Germany, in Hanover. You can see here. The patient is non-intubated. For multiportal, it will be difficult to do non-intubated because if you have 5 trocars attacking the patient and the patient moves, or it's dangerous with the robot because you cannot remove easily. But with the uniportal, is through a utility incision, you can undock the patient in 30 seconds. The 3 arms, very quick, so it's safer. Here you can see the patient, for example, here in Hanover, was moving too much. Was not intubated, moving too much. So I didn't like it, the case for this session. And of course, one of the things that we have the robot is the complex cases like this, chemo radiation, immunotherapy, crazy case. You can see this patient. So in this case, you have to do from bottom to top. Everything was stuck. Everything was stuck here. We opened the pericardium. The SBC was completely stuck. Really challenging case. And you can see that here we have some bleeding on the PA because it was stuck, but we control the bleeding with the robot. So we have a bleeding always, keep calm, compress and wait. And here we go from posteriorly, we cut the bronchus, we do bronchoplasty from behind, but you can see the problem that the artery and the azygos vein were stuck because of the radiation together. So they are very challenging cases. And of course, you need to have a very good team, very good assistant to do these cases. You can see there's a bleeding here, but we can put a stapler here. You see, stapler to finish the operation. The robotic staplers are good, but if not, we can do hybrid with the Panther staplers, for example, are perfect. When we do hybrid URATs, we use Panther. So here we use the stapler. As you can see, there's some bleeding, still some, because the artery was completely stuck. See here? But I think the robot gives a very good precision to here. Of course, you have to be very experienced with this case. They are dangerous. But the robot gives you this precision to control the artery and to suture the artery. Of course, you need to know that these cases are really hard. And then when we finish the artery, we just close the bronchus. And this patient did very well. Portal, incision, and lobectomy done. Very challenging, super challenging. Because this patient has palliative radiation, 66 rays, plus immunotherapy, plus chemo. And then 2 years later, because of the good response, the oncologist called me, Diego, can you do something for this? Can you do lobectomy? I say, my God, very hard. As you can see how is the hilum here. Look at this. Look look. There's no place. Look, this is the azygos vein. We cannot even see the azygos here. Here, look, completely stuck. Even we have to sacrifice the azygos from posteriorly, but from anteriorly it was totally crazy. You can see? Yeah. So in this case, this is why we open the fissure initially from anteriorly. And then we leave the hilum for the last. And then we go from bottom to top. It's very important. When you have blocked this, leave the artery for the end. So go for the fissure, do everything, and leave the bronchus and the artery for the end, because you have always control of clamping or do whatever. Even in this case, look, when we open the intrapericardial, this is the SBC. The SBC was blocked here. We cannot even go deeper. You see? Here, block. This is the SBC. This is the main PA here. Completely blocked. Really, really hard. Absolutely crazy. This is why it's very important, and this is why here we have one bleeding at the beginning from the artery. You can see this is the artery here. With the suction, my assistant break partially the branch for it. But in this case, keep calm, put a compression, this is the fissure, and wait. And continue working. This is one of the concepts that is very important to tell to the beginners, okay? You have some bleeding, just compress, keep calm, wait. Don't be in a hurry. Cut the bronchus, and when you cut the bronchus, you will see better behind. But you see the tissue was completely. So with the 8mm staplers, these are coming, will improve a lot. For uniportal will be amazing. 8mm stapler. You can see here. It will help a lot, no doubt. So less is more. Keep calm, think uniportal. This is the evolution, less invasive approach. If you want to learn uniportal rats, we have a course only for teaching uniportal rats in Bucharest in June with fully robotic. It's very, very useful. If you want to learn the story, this is the book, When Nothing is Impossible. I already shared yesterday in the World Thoracic group, so you can have it. And remember that everything begins when you leave your comfort zone. So if you want to learn something, don't forget to leave your comfort zone. And you have to take always some risk in life. But every risk you take should be under control. For example, people may think I'm crazy here. This is the Devil Pool, okay? In Zambia, in Victoria Falls. Of course, if I fall down, I will die. But if you want to enjoy this moment, you just put the hand on the rock, smile, and take the photo. If you try to do a selfie, I will die. So this is the same in thoracic surgery. If you want to learn something, you have to do it slowly with a proctor. This is in Namibia. If I want to do skydiving alone, I will jump, I will die. If my first jump is alone, I will die. So my first jump is with a proctor. My second jump is with a proctor. Maybe my third is alone. We'll see. You understand? So it's in thoracic surgery is the same. If you want to do something, be with a proctor first. Follow the steps. Don't think that, okay, if you see some expert, oh, it looks easy, I want to do. No, because everything looks easier when you see an expert. So if you want to do something, do it slowly, step by step. Everything I do is because of my background. If I do a uniportal double sleeve robotic, it's because I have done hundreds of sleeves before by uniportal. And before uniportal, I did hundreds of sleeves in transplantation. So everything I do is because I'm following the experience. So don't misunderstand, don't be confused about others who are experiencing something. You have to follow your path slowly with your experience. The most important is be safe. Don't make mistakes. Go to the correct training. Go to high volume centers. Come to courses like this because it's the best example for learning. If we do it annually you should come, do the cadaver, and then slowly go back to your institution, start the technique, call a proctor, call another surgeon from maybe India or internationally, wherever, to help you in your first cases. And then step by step, you will build your program. But the most important, be safe. Thank you.
Thank you. Thank you, Diego. I think that is a wonderful master class. You have, I think, in 1 hour shown us the past, present, and future of thoracic surgery. So you are a pioneer and you are pushing the boundaries. So what's your future prediction for thoracic oncology? What is left? So natural orifice?
Well, it's difficult to know. It's difficult to know what is the future. I think the future is the less invasive approach. Could be some kind of natural orifice, but nowadays, it's a little bit big. It's a big operation if you go through the natural orifice. If you're going to reach the lung and you have to perforate the trachea, is a little bit of too much. Eh? So, but we have to believe in the future. I think the future is a uniportal with a lot of technology, very, very small incision, maybe some kind of micro robots inside the chest, and of course, combination of immunotherapy, target therapies. So there are a lot of improvements in lung cancer therapies in the future. We have to continue working on the less invasive approaches because otherwise the oncologist will have all the patients. So because they are doing better radiation, better chemotherapy, better immunotherapy, we need to offer a good solution with a less invasive approach and the most radical treatment. This is why it's so important to be focused on the less invasive approach. Otherwise, if you have a lung cancer and you do a thoracotomy, maybe the oncologist will not send to you. Oh, it's too invasive. I will send to the radiologist. They will do SBRT, and the result for a small tumor is the same, right? This is why it's important to work on the. No doubt, technology is the future. Robotic is the future. I don't know what kind of robotic will be the future, but for sure, uniportal will be the way to follow because all the platforms now are working on this kind of system. And this is why robotic allows to do this. So I'm sure that will be aligned with the robotic lung cancer surgery.
Good morning, Diego. One
Hello.
question I want to ask. This was a fantastic presentation and
Thank you.
it was really enjoy. Everybody has tried. I just want to ask, you have seen anesthesia over here, and this must be one of the best, it's like we have tried our level best. What is the scope of improvement based on your extensive experience in this kind of surgery? Is there anything which we could have done better or
For anesthesia.
anesthesia point of view? Sir?
Well, I think for anesthesia,
What do you expect from an anesthetist to be the
Yes.
for your safe surgery?
well, what we are seeing nowadays in our experience is that the anesthetists are being less and less invasive. They are aligned with us. So this is something that is very interesting because thoracic surgery has evolved to the less invasive approach. Okay, we do now uniportal, non-intubated, very minimal invasive, single hole, and anesthesia should follow the same. So we are now in our institution moving to a concept of tubeless. That means do no epidural, no venous catheter, no central vein, no catheter for the urinary catheter. So try to do the less invasive and sometimes no intubated. So this is one of the things that we are working with our anesthetists to do a fast track, to allow the patient to faster recovery. So we work together, and I think nowadays most of the cases can be managed with this. Without the central line, we don't put central line now, most of the patients, unless the patient is old. So we try to minimize the anesthetic, invasion, because sometimes if you think about what is something for a patient is a lot of invasion. Put the central vein, you put the catheter, epidural. So we try to avoid this, make a smaller risk for the patient. I think this is one of the things for the future.
Thank you very much. Very good insight you have given. Thanks a lot.
So even for anesthesia, less is more.
Yeah, less is more, of course. But I think this needs time to be confident with your anesthetist. He will be confident with you. Of course, for the anesthetist, it's also important to trust in the team, in the surgical team, to say, okay, I'm comfortable with this because you are doing well, you are doing your operations faster. So I don't need if you are faster, you don't need the urinary catheter, for example, because if the operation is 1 hour, you don't need to put the urinary catheter. Of course, if you expect that the surgery will be 5 hours, you need to put the urinary catheter because not too fair for the patient. So it's about being working together, being confident, and the most important, being a team. I always say that the anesthetist will be your best friend, not your enemy. If your anesthetist is your enemy, is when you never evolve. You never evolve because you are afraid of him, he's afraid of you. So you do everything wrong. So you have to be friends, you have to talk, you have to, and this is the most important thing.
Thank you. Any comments or anybody would like to? So it was a spell bonding masterclass. Anybody? Yes, Dr. Abhijit.
Thank you, sir. You are inspiration for all of us. I wanted to ask you about esophagectomy because we are doing VATS esophagectomy. Do we see any evolution in dealing with esophagus, like a uniportal kind of approach?
Well, I did some esophagectomies a long time ago. When they ask me, I do it, but I normally don't do esophagectomies. And I did some uniportal esophagectomies many years ago. But I think now you can do uniportal. I think for esophagectomy, uniportal is a very good technique because you have this bimanual instrumentation, you have a good view. And of course, nowadays you can do minimal invasive esophagectomy and with the robot perfectly. So I think depends on your experience, but uniportal is ideal for esophagectomy, I think. If you have experience, of course, in esophagus, we have one colleague, he can give his experience, he can tell about his experience.
Yeah, yesterday I was discussing with Professor Diego. Yes, you can do the esophagectomy McEwen's Ivor Lewis single port. We have just completed the 50 cases uniportal esophagectomy, all thanks to Professor Diego's training. And so, yes, it can be done. Yeah.
Diego, another, I think we should, as you said, the surgery needs to evolve to compete with the other modalities. So we are talking of precision medicine, personalized medicine. I think even surgery also what we are doing is very precise sort of a surgery and personalized. Every patient is different. So I think the concept, maybe the terminology also we should start changing and using precision surgery or
Yes.
personalized surgery. So to, I think at a global level, so that's what is happening actually in the surgical field.
Yes, yes.
So if you call just minimally invasive, rather than it can be a precision or personalized surgery.
Yes, of
So
course.
that's
Definitely.
what the trend in other oncology fields, like you take medical oncology or radiation oncology. So that is the way forward.
Yes, and multimodal treatment. Multimodal treatment is very important. Lung cancer is is not only a surgical concept. So lung cancer is a very wide concept. So you have to have collaboration with many teams. It's not only surgery. You have to operate, but you have to think about immunotherapy, chemo, physiotherapy, a lot of things. Pulmonology is involved, oncology.
If there are no more questions, we would like to thank Professor Diego for a wonderful lecture. You can interact. He will be around till lunchtime. So thank you, Professor Diego. Thank you. Dr. Sunil.
Pleasure.
Thank you, Professor Diego, for that insightful presentation. Your techniques are truly innovative and futuristic, and we are so glad that you shared them with us. I request Professor Sushma and Professor Dev to please felicitate Dr. Diego. Thank you, sir and ma'am. Thank you, ma'am. We now have a session of neoadjuvant, preoperative, and postoperative management of lung cancer. For chairing this session, I request Dr. Sanjeev Kumar, Consultant Surgical Oncology, Manipal Hospital, Delhi, and Dr. Prashant Gupta, Consultant Surgical Oncology, RNR Hospital, New Delhi, to come to the stage to chair the session. Dr. Ashish Jaketia also, Associate Professor, Department of Surgical Oncology, Gitanjali Medical College and Hospital, Udaipur. Thank you, sir.
After excellent session by Dr. Diego, we'll move on to the next talk. So I would like to invite Dr. Saurav Vig, Assistant Professor, Onco Anesthesia at AIIMS, New Delhi. His topic will be preoperative evaluation and rehab and pre-rehabilitation in thoracic surgeries.
Good morning, everyone. I would like to thank the surgical oncology team, Dr. Dev and Dr. Sunil, for giving me this opportunity, and Dr. Sushma for giving me this lecture over here. So I won't take much of your time. It is a surgical conference and a part of anesthesia. I'll try to be precise. I won't teach anesthesia. So most of you would be thinking why we are having this session. So mostly anesthetists ask some specific investigation. I would like to tell you that there are some logic and reason behind those investigations so that you can act preemptively and know why and when a surgical specialty referral from a medical side is required, so that you can be a step ahead of your anesthetist and get your patient ready for surgery in time. So surgeon is the best person to guarantee a well-prepared patient for surgery, because you are the first point of contact for the surgeon patient. So coming on to the first question every surgeon has, why are so many specialty referrals asked for major surgeries and thoracic surgeries? So the basic dictum is any uncontrolled comorbidity or a newfound abnormality needs to be optimized before surgery. And this won't take much time. If you see the basic vitals and the basic investigations as per your institute and the previous comorbidity status of the patient, you can act in advance and get some specialty referrals before sending the patient to the anesthetist. Now, we ask for lung-specific investigation. Thoracic surgery is a teamwork between the surgeon and the anesthetic. We ask some lung-specific investigations. We kind of insist to get them done. You should know the reason behind them. Most of you are well versed. I'll just point out some specific pointers from the anesthesia side. So what we ask is a PFT, DLCO, sometimes a VQ scan. Some centers have a luxury of a CPET, so we ask for a CPET. Sometimes we write off a pre-op ABG to be done, or sometimes we do a 6-minute walk test or a chair climbing test. I would like, just in my coming slide, I would just give you a reason for each of these tests so that you know that why something is done. and you can act accordingly. So what anesthesia relies on getting a patient ready for thoracic surgery is three-legged stool of pre-thoracotomy respiratory assessment. So the first thing is lung mechanics. So lung mechanics are best judged by the pulmonary function test, forced expiratory volume, forced vital capacity, and the predicted postoperative calculation of the forced expiratory volume, FEV1, and the vital capacity depending on the segments to be resected. So that's why PFT is the first test that is asked for in every patient. Next is the parenchymal function. Getting a PFT and getting a DLCO is not the same thing. DLCO tells us something which a PFT does not. In a patient who has received chemotherapy, PFT may be normal, but the DLCO specifically tells about the gas surface area available for gas exchange, which is viable and working in the lung after the chemotherapy. So that is also important in every case. Next comes is the cardiopulmonary reserve. So cardiopulmonary reserve, postoperatively, most common complications which will be happening are cardiac and pulmonary. So cardiopulmonary reserve needs to be calculated in specific high-risk cases. Most of us don't have a CPET, but a low technology test like a 6-minute walk test, simply asking a patient about his effort tolerance in detail and getting a mental picture about his general physical status, or a stair climbing test, and an exercises SpO2 recording at rest and during 6-minute walk can easily guide you, and no need for a CPET test also. So first of all is the respiratory mechanics. So PFT is the main test. The lung segments are divided. I won't go into too much details. You all know this. So we need the predicted postoperative FEV1. This is the most valid test to predict postoperative respiratory complication in simple lobectomies and bilobectomies, not a pneumonectomy. Pneumonectomy needs a little more advanced level of testing. And there is a simple formula for postoperative FEV1 calculation. All of us can see a PFT, see the lung segments, and calculate a postoperative FEV1 during our preoperative OPD visits only, before anesthetist sees the patient. So its basic use is any resection less than pneumonectomy, PFT has to be done. And a predictive postoperative FEV1 of more than 40%, you are reasonably sure that you can go through the procedure and anesthesia will clear the patient. 30 to 40%, there is some increased risk and you might have to delve deeper into some investigations. And less than 30%, there is a high risk for postoperative respiratory and cardiac complication. Next is the lung parenchymal function, or the diffusion capacity for the carbon monoxide. Or other surrogate tests are ABG values of PaO2 and PaCO2. Most patients will be COPD patients, and PaO2 and PaCO2 values may be altered. That's why we sometimes ask for a room air ABG before going ahead. So DLCO is negatively affected by preoperative chemotherapy and not a simple PFT. That is the point to be noted. And it is useful and is to be done in all resections. The same formula for predicted postoperative FEV1 and predictive postoperative DLCO based on the anatomic lung segments can be used to calculate the predicted postoperative DLCO till lobectomies. Any value less than 40% means some amount of increased risk, and more is to be seen. Now coming on to the cardiopulmonary interaction. Main test is the cardiopulmonary exercise test. Luckily we are blessed to have a cardiopulmonary exercise test over here. The patient you saw yesterday, the inoperable case, we were pretty confident about him tolerating the procedure, not by the surgical aspect from the anesthesia side, because his CPET values were 17. VO2 max was 17.5 ml per kg, and he did the CPET pretty well for his post cardiopulmonary bypass status. So we were pretty okay with that. Its use is in high risk cases. I'll tell you in a flowchart in the next slide which cases are specifically indicated for a CPET, and a surrogate test will not be useful for that. And I'll also tell you which surrogate test can be done in a patient which has borderline values. So interpretation is VO2 max value of VO2 is the pulse, oxygenation pulse. So VO2 max value of 20 ml per kg per minute or more is minimal risk. 15 to 20, there is reasonably safe zone. Patient has some reserve. Less than 10, there is a very high risk. So if you are doing a low, you don't have CPET and you are doing a low technology test, like 6-minute walk test and stair climbing tests are two tests which are generally referred in terms anesthesia books as low technology tests. So if you mark 2 points and tell the patient to take lap for 6 minutes in between those 2 points, and calculate the total distance and divide it by in meters and divide it by 30, you get an approximate value of what would be the VO2 max. Suppose if 450 meters are walked in 6 minutes and you divide it by 30, the VO2 max will be around 15 ml per kg per minute. So if you simply ask the patient how many flights of stairs you can climb, each flight of stairs should be around 20 steps. And if you can climb 2 flights of stairs, 2 floors, VO2 max is above 10 safely. If they can climb 5 floors, VO2 max is above 20. That is a near approximation. They are not very accurate tests, but they can be judged for approximation. So next question is VQ scan. Mostly surgeons themselves judge when to get a VQ scan, when to get not. But when we ask for a VQ scan, it is usually, its use is not generally indicated in a lobectomy or a bilobectomy. But when you are planning for a pneumonectomy, you have to get a VQ scan done to see the functional aspect of the lung and calculate the functional aspect which will be left after the surgery. And the dictum which we generally follow is evaluate every bilobectomy or sleeve resection as a potential pneumonectomy candidate for intra-op change in plan. So that is what we follow. And now I'll show you the overall picture. Firstly, the functional capacity is to be judged in every patient. Then comes the spirometry. The first leg of the stool is to be done in every patient. If the value is absolute, more than 60%, you can go ahead with your surgery until a lobectomy. Pneumonectomy, a little more investigations are to be done. If it is 60 to 30%, that is the gray zone. So 60 to 30% is the gray zone. But if it is less than 30%, that is absolutely indicated for a high intensity cardiac testing. That is the cardiopulmonary test, less than 30%. 60 to 30%, you can do a 6-minute walk test or a exercise stair climbing test. Less than 30%, if you get a cardiopulmonary exercise test done, or you go for a dobutamine stress testing on an echo or a treadmill testing based on the cardiologist's profile at your hospital. So now this was the basic lung and cardiac interaction which happens for the surgery. I will not take much of the time and I will quickly jump on. Other systems have also to be looked into detail. You cannot just see cardiac and pulmonary and make the patient fit. So you can be a step ahead if you're an anesthetist. So in pneumonectomy cases, post-operatively, we are worried on right heart strain, increased right heart pressures, right heart pulmonary hypertension. So we would like to get a 2D echo, rule out right heart strain pattern at the onset. Respiratory, mostly patients will be COPD. They have to be optimized before surgery. Smoking cessation, preoperative spirometry, treatment of lung infections. These are the basic steps which have to be taken care in every hospital. Most of this is a part of general ERAS pathways of every hospital. So I'll not be discussing ERAS in details. This will be the next session, just following me. Other organ-based evaluation system, neurology and renal dysfunction. So renal dysfunction is specific. If there is a renal dysfunction, the anesthetists are usually very fond of risk indices. We usually say a cardiac risk index or a revised cardiac risk index for a thoracic case. They usually have a creat level cutoff of less than 1.5 as normal. If it is more than 1.5, the risk increases and has to be evaluated. A neurology patient, pre-existing comorbidity, other illnesses, they have to be looked and dealt as case by case basis. So I'll be very precise, I'll wind up here. So the take-home message is very simple. There is a close teamwork, as every senior has already told. And there should be a close teamwork between anesthetist and surgeon for optimal outcomes. There should be a basic clarity on other branches concern, which will help you to act preemptively as a surgeon. And open, clear-ended communication between surgeon and anesthetist would be your recipe for success for an optimal outcome in thoracic case. So thank you, and hopefully you have had a pleasant stay at NCI. Any questions?
Thank you, Dr. Saurabh. It was an excellent talk. If there are no questions, I think we are already running late. So I would like to invite our next speaker, Dr. Brajesh, who is Assistant Professor, Onco Anesthesia at AIIMS, New Delhi. He'll be speaking on enhanced recovery after thoracic surgeries, the practical aspects. Dr. Brajesh, please.
Very good morning to all of you. I'm very thankful to Dev sir, Susma ma'am, and the organizing team for providing me this opportunity. I'll be discussing briefly about the enhanced recovery in thoracic surgeries. About the history of ERAS in 2001, Dr. Keen and Dr. Ole has a meeting in nutritional symposium, and they decided to work on perioperative care. And in 2003, the first ERAS symposium has been held in Stockholm. In 2005, first ERAS protocol has been published, which is for colonic surgery. And in 2019, first guideline on esophagectomy and lung surgeries were published. This is a systemic review in which 38 articles has been included, and 5,100 participants are there. And it includes the colorectal, thoracic, and upper GI, and also includes the joint surgeries. And in this review, they found that the reduction in primary hospital is by 1 day, and the 30% reduction risk was there in post-operative 30 days. And there is no evidence of any increase in death or any major complications. Now, why implementation of ERAS is important? Because it decreases the length of hospital stay. So the patient will be early discharged, decreases healthcare cost. Patient become early return to their work and increase their productivity. It also decreases the surgical and non-surgical complications, increase the patient turnover, so we can have more patient in that period. How ERAS works? Basically, in ERAS, we address the patient's related issues during his preoperative visits, and we target to increase patient's functional status preoperatively, so which will be helpful in perioperative period, and it finally decreases the postoperative complications and postoperative hospital stay. This is another systemic review. In it, 21 studies has been included with 5 RCTs. They studied the different exercise tolerance and exercise done by the patients. It has a different duration of exercise for 4 weeks with 5 sessions per week, and type of exercise may be moderate to high. And finally, they found that there is improvement in peak oxygen consumption, or there is increase in functional capacity in form of 6-minute walk test. They also found that the lung function is also increased, enhanced, and the prehabilitation compared to previous status. And it also decreases the length of stay and pulmonary complications. About the preoperative fasting and anxiety, in ERAS, it allows to give clear fluids till 2 hours before the surgery, and for the solids 6 hours before the induction of anesthesia. oral carbohydrate loading will reduces the postoperative insulin resistance, anxiety, and patients remain metabolically fed, improves preoperative well-being, decreases catabolism, and maintain lean body mass and muscle strength. For preoperative carbohydrate loading, we can use 5% glucose, cranberry cocktails, and along with all this preoperative information, counseling, and education to the patient is also decreases the perioperative anxiety. Along with this, non-pharmacological interventions like relaxation technique or music therapy are also helpful. About the venous thromboembolic prophylaxis, for high-risk patient, it should be given in form of mechanical prophylaxis, and for low-risk patients, we must include the pharmacological therapies in form of low molecular weight heparin or unfractionated heparins. This is the capital. It would be used for the risk assessment of prophylaxis and skin preparation. I think you all were aware about all this, and I'm not going any detail about this. About the preventing intraoperative hypothermia, it is a very important to keep patient normothermic, especially in case of open thoracotomy. There is increased chances of hypothermia. Protocol is to use DLT for one lung ventilation. In case of difficult airway, bronchial blockers should be used, and all this, all above DLT and bronchial blockers should be placed under fiber optic guidance. Lung protective ventilation should be given in form of low tidal volume, and optimum PEEP should be used, and alveolar recruitment before one lung ventilation is improve oxygenation. About the post-operative nausea and vomiting, post-operative nausea and vomiting is the most common cause of patient dissatisfaction during immediate post-operative period. There are multiple etiological factors that may be patient-related, anesthesia drug-related, or surgery-related. And simplified FL score can be used for assessment. And regional anesthesia and use of NSAIDs has a opioid sparing effect. So they can decreases the further post-operative nausea vomiting. And a common approach is to use one drug as in a prophylaxis. And if patient have post-operative nausea vomiting, then another class of drugs should be used. This is the risk stratification prophylaxis guidelines for post-operative nausea vomiting. About the regional anesthesia and pain relief, for major thoracic surgeries, thoracic epidural is still gold standard, but we can consider to use paravertebral block, erector spinae plane block, serratus anterior plane block. Acetaminophen and NSAIDs should be considered until unless they are not contraindicated. Dexamethasone has also an important role in preventing post-operative nausea vomiting, and also it reduces the pain. Ketamine can be considered, especially in patients who are in preoperative pain medications. I'm not going any detail about the perioperative fluid management, but IRAS has recommended to go for a restrictive fluid regimen, and if there is intraoperative hypoperfusion, then vasopressors can be considered. About the atrial fibrillation prevention in thoracic surgeries, the incidence is on around 12%, and risk factors are increased age, male sex, and patient who have a pre-existing cardiopulmonary comorbidities, they have more chances of getting atrial fibrillation in post-operative period. CHADS 2 score can be used for prediction of post-operative atrial fibrillation. There is no recommendation to use any drug for prophylaxis for the prevention of atrial fibrillation. Surgical techniques, you all know about the nerve sparing and muscle sparing thoracotomy, which decreases the post-operative pain. About chest drain is also a common cause for pain in post-operative period, and it also reduces the pulmonary function and immobility. It should be removed as early possible. About the urinary catheter drainage, it should also be recommended that it should not use for the monitoring of urine output in post-operative period. So epidural anesthesia may have associated with post-operative urinary retention. So it can be continued till the epidural catheter was placed. And prolonged urinary drainage may, catheter placement may increase the chances of UTI. About early mobilization and adjuncts in physiotherapy, early mobilization within 24 hours will included in ERAS protocol, and bed rest may causes physical deconditioning, diminishes the muscle mass, increase pulmonary complication and venous thromboembolism. Chest tube, urinary catheter, continue intravenous fluid
Dr.
and
Brajesh,
inadequate pain
if you can
control
wrap up.
or barrier to early ambulation. And routine post-operative non-invasive positive pressure ventilation is not recommended. At the end, I would like to tell the pre-operative assessment and intraoperative proper management along with the multidisciplinary team approach with surgeon and anesthetists and active involvement of patients may give a better outcome. Thank you.
Thank you, Dr. Brajesh. Is there for Dr. Brajesh from the audience?
Excellent talk, Dr. Brajesh. Just a question. So these patients are managed largely by the collaborative teamwork between surgeon, anesthetist, ICU, and critical team in the peri-operative period. What do you feel is the biggest gap from surgeon side, your perspective and honest comment?
We have a very good collaboration in our institute. We are getting a good collaboration, and I don't think I haven't seen any kind of from our surgical.
Thank you, Dr. Brajesh. I now request Dr. Prabhat Malik, Additional Professor Medical Oncology at IRCH, AIIMS, New Delhi, to present his talk on neoadjuvant treatment in locally advanced lung cancer, medical oncology perspective. Dr. Prabhat, please.
A very good morning to you. And at the outset, thank you very much, Professor Dev and Professor Sunil and the entire organizing team for giving me this opportunity. And in fact, today I got the opportunity to see this wonderful, amazing advancements in minimal invasive surgery. It was quite amazing. Next few minutes, probably I would be covering some of the advancements in medical oncology field and how these advancements have made surgeons' life easy or difficult. Maybe you are the best just to tell that. I will just give you the brief glimpse that the changes we are seeing in the area of lung cancer, the way we manage the early and advanced disease today. So if we talk about stage 3 disease or locally advanced disease in general, what we say, this is a very heterogeneous group. It's not just one stage of disease that stage 3 lung cancer is managed this way. So on one hand, you have stage, 3A, where like a group of patients who are potentially operable, even operable upfront. Then on the other extreme, you have stage 3C, where some of your patients may not be even amenable for a radical intent treatment. Forget about surgery. So this is the entire spectrum of stage 3 disease, or broadly what we call locally advanced disease. All of you would agree that medical oncology has made reasonable progress, particularly in lung cancer over the last 1 or 2 decades. We have seen significant improvement in survival for advanced stage disease. The way we manage stage 4 lung cancer today is totally different what we have been in fact taught in our training period. Gradually, these agents like immunotherapy and targeted agents now are entering into locally advanced domain. We have now mature data of using immunotherapy post-definitive CTRT, and we have shown that, that it improves survival significantly. And now these agents are entering into more early disease where the surgical roles come. everybody knows that once you operate non-small cell lung cancer, these patients require adjuvant chemotherapy. And the absolute benefit in terms of improvement in survival, although statistically significant, but to the magnitude of 5%. You may not be impressed with this kind of results, but that was the standard of care for us for so many years. Generally, neoadjuvant treatment have been reserved. I mean, we did have more data or more evidence for operable disease that using surgery first, then followed by adjuvant chemotherapy. But gradually the paradigm is shifting, and I would tell you how. But so far, the neoadjuvant strategies have been reserved for patients, a group of patients who were potentially resectable and stage 3 disease. Some of the studies have included stage 2B as well, but this paradigm is now changing and it's entering into the early resectable disease as well. Can we use targeted agents? This is something we are yet to see. As far as preoperative chemotherapy is concerned, when we didn't have targeted drugs and immunotherapy, these were the results. This was the meta-analysis of all the neoadjuvant trials, which again showed that the absolute improvement in survival is more or less similar what you get with adjuvant chemotherapy. But the problem here was that most of the studies included in this meta-analysis were very small studies. The evidence was poor, so that's why the practice was more towards surgery followed by adjuvant chemo. But what we knew from this trial that it doesn't really matter whether you give preoperative chemotherapy or post-operative chemotherapy. With both the strategies, the survival are more or less same. The advantage of using neoadjuvant chemotherapy was that more and more patients were able to receive systemic treatment and complete systemic treatment because tolerance is relatively poor post-operatively. So like both these strategies have their own advantages and disadvantages. So pre-op strategy, more patients complete treatment, you have better tolerance. You can treat micrometastatic disease because we know that so locally advanced lung cancer is practically a systemic disease, not just a regional disease. And so there is a downside that there's theoretical chance of disease progression during the neoadjuvant period, and your patient who was potentially operable may become completely inoperable. And then you don't get the accurate surgical stage by your pathological staging. On the other hand, post-operative strategy, you get your definitive treatment on time, more robust data is available, but the problem is the poor tolerance and that lesser number of patients receive treatment. What treatment to be given, whether it's chemotherapy or chemoradiotherapy, this again an older study which randomized patients who were to be given neoadjuvant treatment, chemotherapy versus chemo-RT, and there was no difference neither in disease-free survival nor in overall survival. Despite having more patients undergoing R0 resection and more mediastinal nodal sterilization, but it did not translate into better survival. So practically neoadjuvant chemotherapy have been more or less the standard of care. Except for a few cases of Pancoast tumor where we reserve preoperative chemoradiation as a standard approach. We did, this is our own experience from our own center of using neoadjuvant chemotherapy before surgery. These are the patients who were operated after neoadjuvant chemotherapy. So denominator is not that all patients who receive neoadjuvant chemotherapy, the denominator is patients who could undergo surgery. So there is a selection bias. But it does give us a little bit of confidence there's a number of patients actually achieving a pathological response. The number may look a little high. This is 10 out of 44, but it is again because of the selection bias. We are analyzing only the cases who are operated. So they are anyway the good respond. And what we at least understand from this analysis that patients who achieve a pathological response, they have a reasonably good disease-free survival and overall survival. And at least if you are able to achieve N0 or N1 status, so you improve outcomes of these patients. But patients who retain the N2 status even after neoadjuvant chemotherapy, they have their survivals are not really good. And this did translate into overall survival benefit. We do have another experience from Tata Memorial Center of using preoperative chemotherapy. They use for non-squamous histology. This is again a controversy whether we should pemetrexed-based regimen or all third-generation regimens are okay. So this is their experience of using pemetrexed platinum combination. 61 patients operated after neoadjuvant chemotherapy. The objective response rates have been around 35%. And what they showed that patients who could receive a definitive treatment after neoadjuvant treatment, they had better outcomes as compared to patients who were treated with systemic treatment alone. Looking at our initial experience that many of our patients are actually achieving a pathological response. So we thought that why not to improvise on intensity of treatment, what we have learned from breast cancer and ovarian cancer management, that using dose-dense chemotherapy may improve the response rates. And that's what probably we need in neoadjuvant setting. So we designed this small phase 2 study using Taxol as a dose-dense regimen. Although a small study, after 37, only 17 patients were operated, but and majority of the patients were stage 3A by virtue of N2 disease. What was interesting here that the objective response rates were quite impressive. There was a 75% objective response rate, and we were able to maintain the dose intensity in majority of the patients. Mean RDI was 88.6%. These are the indices we use in dose-dense strategies. So this regimen was reasonably safe, and it does give us the good objective response rate. We cannot comment on pathological response rate, and that was not the primary endpoint of the study. This was just a feasibility study. The interest of using checkpoint inhibitors in operable diseases came from this landmark paper, although very small study of 21 patients published in New England Journal of Medicine. Just giving 2 doses of nivolumab in all operable cases, like patients who are waiting for your surgery, just give 2 doses of nivolumab. And what they showed that 9 out of these 21 patients achieve a major pathologic. I would require. Thank you. So, and this was very interesting that it was not only the radiological response you get. In first figure, you can see that radiologically, this patient had a very good response. And when you resected these tumors, the tumor was completely replaced by immune infiltrate. On the other hand, you had the other extreme, that patient, radiologically, if you see that, you would say it has not responded, rather it increased in size. But when they operated, this was predominantly the immune infiltration and hardly any residual tumor. So from there, this interest emerged that we can actually use neoadjuvant, we can use immune checkpoint inhibitor in the operable disease, and it can induce pathological response. So this led to the design of this phase 2 trial. Again, it was not a randomized trial, a single arm study. And they combined chemotherapy with nivolumab, 3 cycles. And you can see 63% complete pathological responses. And these responses were durable. This is a small phase 2 trial, not practice changing, but it's thought provoking that you are able to induce pathological responses in a significant proportion of these patients. And with the chemotherapy era, the pathological responses were hardly seen, maybe 5 to 10%. That was the experience. From there, the jump was to 63%. And now, subsequently, several other agents were tried, and the pathological responses were, these findings were confirmed. Then this landmark phase 3 randomized trial, which has actually changed the practice globally, is this called Checkmate 816 study, where they randomized patients from stage 1B to 3A, that is potentially resectable non-small cell lung cancer. The condition was that these patients should not harbor EGFR and ALK rearrangement, because these patients do not benefit with checkpoint inhibitor. They were randomized to chemoimmunotherapy versus chemotherapy, a platinum-based standard chemotherapy based on histology, whichever your institute follow. Then after 3 cycle, radiological assessment and surgery within 6 weeks, and pathological response rates and event-free survival was their primary endpoint. And amazingly, it led to 25% complete pathological responses with the combination. So this number, although looks smaller than the previous one, but those were selective phase 2 small study. This is a large randomized study. So this is much more replicable on day-to-day clinical practice, but even 24% is quite amazing. 45% has major pathological response, what you define as less than 10% of viable tumor. And all the subgroups were actually, if you look at that, who are the group which do get a pathological response, practically everybody was getting pathological response, except for a small proportion of patients who were never smokers. Maybe these were more of driver mutation positive patients apart from EGFR and ALK. because we know even for rare driver mutation positive patients, immunotherapy doesn't work that well. And it did translate into event-free survival benefit. There is trend toward overall survival advantage, but the data is not yet mature. We cannot say it with conviction. And what they showed here that if you achieve a pathological response, it translates into an EFS benefit. Doesn't matter whether you are getting a pathological response by chemotherapy or by addition of immunotherapy to chemo. These patients who are achieving a pathological response, they are living long. And the surgical outcomes were comparable whether you are using neoadjuvant chemotherapy or neoadjuvant chemoimmunotherapy, again giving some confidence that radical surgeries and R0 resections are feasible. It's not really increasing the complication rates too much. The next question is, like, we see that driver mutation positive patients benefit best with the targeted agents. Can we use these agents in neoadjuvant setting as well? For patients, for example, if they are EGFR positive or ALK positive? Initial phase 2 study have shown that they do, you do get objective responses, but these studies did not translate into pathological response. And pathological response rates in the initial phase 2 smaller studies have been practically nil. There is an ongoing phase 3 trial when we are part of this study where they are actually randomizing patients who are EGFR positive and have a potentially resectable disease. They are randomizing them to osimertinib alone versus osimertinib with chemotherapy versus chemotherapy alone in neoadjuvant setting. And they are trying to look at the pathological response rate. Once we have the mature results of this study, probably our practice might also change for this group of patients. Another interesting strategy which is coming up in this area is assessment of residual disease. I mean, when we resect the tumor and we say that it's an R0 resection, we have practically cured the disease, whether that's true or not, or can we identify the high-risk patients who would probably benefit with our intensification of adjuvant treatment? So that is something which is upcoming. ctDNA assessment can probably help us. This initial study, which is kind of proof of concept study, did show that, I mean, particularly in chemoradiation setting, we do have a lot of confusion whether post CTRT, when PET scans are not confirmed whether this is a residual disease or whether it's a complete response and post RT changes. This is where these strategies can help us, where they did show that if you clear ctDNA after your definitive treatment, these patients have significantly better outcome. And particularly in surgical setting, if you don't clear ctDNA, whatever you do, these outcomes are inferior. And it correlates very well with the disease recurrence. You can actually detect disease recurrence before clinical or radiological relapse. Another group from China did this very interesting analysis that post-surgery, if the ctDNA is persisting, these patients do badly. And in the subgroup, when they looked at patients who have residual ctDNA, they benefit more with the adjuvant chemotherapy rather than those patients who clears the ctDNA after surgery. So, and this was again further validated in the subgroup of Checkmate 816. They did show that clearance of ctDNA is correlating with pathological responses, and it's correlating with your event-free survival. If you clear ctDNA, be it with chemotherapy, be it chemoimmunotherapy, these patients do better as compared to patients who have residual ctDNA. Again, confirmed in the NADIM trial. So to conclude, my take in this current era, how we should manage or how we would be managing these patients in future. Probably the neoadjuvant chemoimmunotherapy is the new standard of care for these patients. We are able to improve outcomes. At least we have mature data of pathological response rates and data suggesting that these pathological response rates are translating into event-free survival benefit. OS benefit we cannot say because the data is not yet mature, but that too with just 3 cycles of immunotherapy. If you ask me what's the best time or the best setting or a most cost-effective way of using immunotherapy, probably this would be this setting where just 3 doses of immunotherapy would lead to a significant improvement in long-term survival. And this particularly much more relevant in Indian setting. And we have data that less than 3% of Indian patients who are eligible for immunotherapy are able to get it. So, and on the other hand, if you operate these patients upfront and you're offering them adjuvant immunotherapy, the protocol is for 1 year. So just imagine the difference. So far, we do not have that comparison whether giving neoadjuvant immuno versus adjuvant immuno, which is better. But whatever data is available, it seems that's the best and the smartest way to use. Whether we can use neoadjuvant TKI, that is still under evaluation, and I think ctDNA is going to be the next response evaluator in future. Thank you very much.
Thank you, Dr. Prabhat, for giving insights on immunotherapy in neoadjuvant setting and also ctDNA, which is these two drugs will be coming in a big way in the future. Any questions for Dr. Prabhat?
It's not a question. As I'm telling, like a pathological complete response will it gradually. That's coming with like immune checkpoints, giving neoadjuvant immunotherapy. How will I suppose complete response after neo?
How do we assess?
Surgery or go for observation?
I mean, so far, we cannot say that we can simply go for observation. I mean, we do have to go for surgery. Then, and radiological assessment is not the best way to do it. You do get these response. We do get situations where there's no response radiologically, and it's a major pathological response.
I think this is still evolving. We should offer surgery till we have very solid data regarding the radiology. You have shown the size may not decrease, but you have a lot of changes which is happening in the tumor bed. I think we need to study all this. Surgery should be part of standard of care for.
So basically, sir, this is probably going to give rise to few more debates. So, I mean, one, which sir said that whether we need surgery if you're getting up a complete pathological response, or if there's some residual tumor, we can simply irradiate it, just get away with surgery. But you would never know whether there's a pathological response without doing surgery. That is number one, because if the assessment by ctDNA is to that purity or that sensitivity level that you can say that this is completely cured, probably you can. Before, I mean, just a couple of years back, majority of the time we used to have this debate in thoracic oncology conferences for locally advanced TTRT versus surgery, which is good. I used to say that nothing is good, both are equally bad. It was because we did not have good systemic treatment for these group of patients. Majority of the patients were recurring systemically. But now again, this new debate has come whether to give neoadjuvant chemoimmuno versus surgery versus just giving chemo radiation and then giving adjuvant immunotherapy. That's another debate which is coming up.
So Prabhat, very nice lecture. Always pleasure to speak. My question is, there are other things which happen with immunotherapy, right? The lung gets damaged. You have a lot of many patients whom we see in the metastatic setting. They have lung issues after immunotherapy. What caution you would like to give to surgeons? Because I think you have to give through some effects of treatment that immuno does to the lung, and we should be cautious about. That is one. Need to answer those. And second thing is, I think we at our institution have a very aggressive medical oncology. Aggressive, I mean that they don't take all the patients for chemotherapy. They are aggressive because after neoadjuvant immuno or chemo, they want us to operate everybody.
Right.
Because they are seeing more of these patients being alive and then coming with residual disease, and you don't know what it is, and they want to cure these patients. So I think as surgeons, we must get better at managing. These are difficult cases. These are not easy to do. And total philosophy of surgery changed. But these two things, I would like your opinion.
Sure. So, I mean, one point is that what trial data so far you have seen, these are carefully selected patients. So the bottom line is the careful selection. What we have learned over a period of time by using these agents in advanced disease setting, that not all the patients are eligible for immunotherapy. So those exclusion criteria, if your patient has a pre-existing ILD, be very careful. If your patient has a pre-existing autoimmune condition, majority of the trials have excluded these patients. Regarding the surgical complications and the surgical concerns after use of neoadjuvant immunotherapy, probably I think the experience is growing. At least what trial data shows that the complications rates are comparable. Particularly in lung cancer setting, practically majority of the patients are smokers. They have compromised lung functions. And if they have some pre-existing ILD, if it worsens, it can make your job even more complicated. So these are some of the things which we have to be careful about. And the best way to select your patient would be discuss all these patients in an MDT, where they should be like when you're deciding that this patient is going on neoadjuvant chemoimmunotherapy followed by surgery path, that the anesthetist should see, the pulmonologist should see, and the surgeon should be confident I'm going to operate on this patient. This patient is surgically fit. This patient is eligible for immunotherapy and fit enough for chemotherapy. Maybe that would be the best way to get the best out of it. But the experience is gradually growing. Maybe after a couple of years, you would not have these kind of apprehension. You would say that it's not very much different because every patient would come to you after exposure to immunotherapy, then you would get used to it.
Small comment, Prabhat. I think lung cancer is little, I think, slow to catch up. Seeing these situations evolving in breast cancer, achieving CRs, radiological and clinical. This has been going on for last 10 years. But what they are struggling is to find out the best way to predict pathological CR without surgery. So for rectal cancer, we have multiple approaches, various scans, MRs, PET, multiple biopsies. Similarly, for breast cancer, now there is a trial published from MD Anderson, doing only multiple core biopsies and following them. I think we need to take leads from other solid tumor models because lung, I think, is too early to say that.
Yeah. But absolutely, the way these, the sequencing techniques are evolving, and now it is becoming accessible to a number of patients, and they are cheaper now. So the liquid biopsy and ctDNA evaluation in many cancer type efforts correlating. Probably the challenge is to find out the best cutoff, the threshold values where we should say negative and all. Once we have bigger data and mature data, probably we are moving towards that side, calling it a precision oncology in true sense. Thank you.
This discussion is endless. Okay, one more question.
Yeah, this is a question to all the surgeons who have operated post and neoadjuvant immunotherapy. So can you just comment on what changes or what difficulties you have faced? Any of the surgeons?
Like I said, we are part of the trials which are doing neoadjuvant immuno. We have 2 trials ongoing. So I don't know whether they have received immuno or not, but certain patients, they are really tough, especially if the disease is on the hilum. So most of these patients, I tend to start everything minimal access, but when you do that also, you get vascular control first, like what Dr. Diego showed yesterday, and then you proceed forward. Sometimes you have to do divestment. You would have seen in pancreatic cancer, we do divestment, right? The triangle operation, how you go periadventitial, you have to do that kind of situation. Sometimes the artery is encased completely, but when you go near the plane, you will see a nice pseudocapsule around the vessel, and you can come away without vascular resection. So, but we send that tissue for frozen, and if it's negative, then we preserve the artery. Otherwise, we have to do a sleeve resection. So it is difficult. You have to be very careful, like you mentioned, that if the patient has pneumonitis, in your reassessment scan, CT scan, lung is showing some GGOs because of post-immuno. I think it's good to give them time to, give them 1 or 2 months time to clear those small pneumonitic patches. Make sure that they're in the best of lung health before they come. So we send it to pulmonologists, make sure that they're optimized, give them good prehabilitation, and they come for surgery because these are not easy operations.
So I'd like to interrupt. The discussion will be endless. That is the reason surgeon's perspective is also important. There has to be a crosstalk between surgeon, radiation oncologist, and a medical oncologist. So thank you, Dr. Prabhat, for the excellent talk. So we'll move on to the next lecture. I would like to invite Dr. Aman Sharma, Assistant Professor, Radiation Oncology, NCI Jhajjar. The topic will be neoadjuvant treatment in locally advanced lung cancer, radiation oncology perspective.
Good morning, everyone. Firstly, I congratulate the entire organizers for such a wonderful academic sessions, and special thanks to Professor Deo and Professor Sunil. And it's been really enlightening for me to listen to the minimal invasive surgery techniques by Dr. Diego. So not taking much of your time, I have tried to simplify of whatever I understand of stage 3 lung cancer. So the neoadjuvant, my topic is neoadjuvant therapy in locally advanced non-small cell lung cancer, a radiation oncologist perspective. So firstly, it is important to understand what is locally advanced non-small cell lung cancer, and it's a very, very heterogeneous group of tumors, and also there's heterogeneity in terms of the patient cohort. So the prognosis is also very variable, and the tumor can be from T1 to T4, then the nodal status can be from N0 to N3. And even if it is N2, then it can be a simple N2 where a single mediastinal node is involved, or it's a single station, and then it can range then there to a multi-station or multi-zone, and it can be a bulky disease. So it's a very, very heterogeneous, and of course, the treatment options are also very heterogeneous. We don't have a prospective randomized data to suggest whether one local therapy is better than the other one. So broadly, it can be classified into sorry, it can be classified into resectable stage 3 and unresectable stage 3. I'll skip this and I'll come back after some time. So this is the previous prognosis, and we can see that stage 3 was divided into stage 3A, and with a 5-year overall survival of 36%, and 3B, the survival was 5-year OS was 23%. Now the recent classification, stage 3 has been divided into 3A, 3B, and 3C. And again, the survival is split. 3C, 3C has a 5-year OS of 12%. B has a 5-year OS of 24%, and 3A has a survival of 41%. So understanding stage 3 is very, very important. So here you can see that stage 3 is compromises of the worst. So advanced T and advanced N. So T3, T4, and N3 would be stage 3. Very early T1, T2, but advanced ipsilateral mediastinal node would be stage 3A. And then when the T advances, the N comes down in stage 3A. So the T3, N1, and T4, N0, N1. And for 3B, it's never N0 or N1, it's always N2 or N3. So early T1, T2 with N3, or T3, T4 with N2 would be 3 buoyants. That is how the prognosis is. For simple understanding, if it is advanced T and advanced N, the prognosis is very bad. If it is an early small T and fairly advanced N, that would be fine. So this is a simple diagrammatic representation for a stage 3 lung cancer. So if it is a potentially resectable and it is N0, N1, then it should be operated. And I think the picture is very clear. But if it is an N2, then there's a lot of debate in this and needs a multidisciplinary discussion. I don't think that one local therapy is superior to other. We'll talk about this. So this is to be discussed, and then a conjoint decision is to be taken. If it's unresectable, the treatment I would say is more or less clear that we should go in for chemoradiotherapy, which is the standard of care. The another option is you go in for neoadjuvant and operate. We'll see that is it better than chemoradiotherapy or not. So for unresectable, concurrent chemoradiation is the standard of care. Induction followed by surgery is not better than radiotherapy. Even if there's a good response to induction chemotherapy, there's level 1 evidence. This is the landmark EORTC trial, and it was hypothesized that following a response to induction chemotherapy, surgical resection would be superior to thoracic radiotherapy as a loco-regional therapy. So these were the responders, and in responders, they were randomized to surgery or radiation arm. But we can see the results. Both the treatments are equal in terms of progression-free survival or overall survival. Also, there was some subset analysis that we found that those patients, when the surgical extent was lobectomy rather than pneumonectomy, the median OS was 25 months versus 13 months, and it was significant. If there were pathologically N0 or N1, then the median OS was 23 months. And when it was N2, the prognosis was a bit worse, and it was 15 months. Again, statistically significant. And also, if there's a complete resection, then the survival is 24 months versus an incomplete resection, then it is 12 months. And also, these patients were subjected to post-operative radiotherapy, which also improved survival. So even if after response there, you would still need radiation, and then you have to subject the patient to locoregional therapies, which sometimes can produce toxicity. This is another landmark trial published in Lancet in 2009. This this trial addressed whether chemoradiotherapy in a neoadjuvant setting followed by surgery or radical chemoradiotherapy. So in one arm, so it did not include the T4 patients. So T1 to T3 N0 patients were randomized to 1:1 in concurrent chemoradiation, which was 45 gray. And in group 1, they were after CRT, they were subjected to surgery. And in group 2, they were subjected to uninterrupted radiation, and then the dose was radical dose was given of 61 months. What were the results? There was no improvement in OS. So the OS in both arms was same. However, there was improvement in progression-free survival, a modest improvement of roughly 2 months. In the surgery group, there were 8% deaths in the treatment-related versus 2 in the group 2. In the exploratory analysis, OS was improved for patients who underwent lobectomy but not pneumonectomy versus chemoradiotherapy. So here we can see that there's improvement, Kaplan-Meier curve. We can see that improvement in progression-free survival, but not improvement in OS. Another interesting finding was that the patient who were subjected to lobectomy achieved a better OS. But then this is a subset analysis. But of course, this is important finding that if you are going in for surgery, lobectomy should be the preferred, and it should be complete surgery. Pneumonectomy was a little inferior with as compared to concurrent chemoradiation. So this is the meta-analysis published by Shah et al., which addresses whether neoadjuvant chemoradiation or induction chemotherapy. So I'm not a very big fan of induction chemoradiation. I think that one local therapy should be sufficient enough, and it should be combined with systemic therapy. Triple modality should only be reserved to a very, very small subset of fit patients who are at a very high chance of locoregional relapse despite one local therapy. So this meta-analysis states that there's no benefit in survival after adding radiation. The first, we can see the forest plot. There's no advantage of chemoradiotherapy over chemotherapy in a randomized setting, and these were the second forest plot is for the retrospective studies, more or less the same picture, and there's no clear-cut advantage. So the only site where I can think of is a superior sulcus tumor where you can offer chemoradiotherapy and go in for surgery. Then coming on to the resectable. So the message from the unresectable is probably concurrent chemoradiation is the standard of care. Surgery can be offered, but it would not add much in terms of survival advantage, but the options are equally good, and it has to be discussed in a multidisciplinary tumor board and leave it to the patient preference. The definition of resectable has been very, very different from different groups. Given the limitation of time, I would not go into the detail, but I'll go into the crux. So the definition would be like a primary resectable tumor with high probability of clearing pathological margins and complete resection. Any nodal disease in discrete, easily measurable and defined, free from major mediastinal structures, including a great vessel trachea with no individual lymph node greater than 3 centimeters. That was the conclusion when we take all the resectable guidelines together, but I leave it up to the surgeon's discretion. Also important is how did the indication of surgery come? So the British Thoracic Surgery recommended considering surgery in a single station N2 non-small cell lung cancer. How did this come is very important. This data was heavily influenced by IASLC staging data, and where surgery was done for all patients and systemic lymph node sampling was done. And what they found out that a single N1 lymph node, a multi-station N1 lymph node, and a single station N2 lymph node are associated with a similar survival, whereas a multi-station N2 has a worse prognosis, which is 20%, but a single station N2 would be as good as a multi-station N1 disease. So, and the 5 years OS was 30%. That's how the indications of surgery have come. but it's also important that there was a no comparator like like a radiation. So when the indications came, it was all the surgical data. It was there was no comparator of a local therapy. So this is the publication in 2007. Here we can see that a single station N1 or a multi-zone N1 or a single station N2 are associated with the survival of 35%. But when N2 is involving multi-zones, then the survival is falling down. But this is more of a predictive thing rather than choosing for surgery, but it's an option. So what does the European Cancer Organization essential requirement of quality cancer states? This is the recent published article in 2020. It states that for stage 3 patients, locally advanced disease may be offered preoperative therapy, chemotherapy, chemoradiotherapy, plus surgery in selected operable patients. The word is operable, and we know that we have to have a clear-cut margins and a non-bulky disease. Whereas chemoradiotherapy is ideally delivered concomitantly when feasible and tolerable and is the mainstay of majority of the cases. When a tumor is de novo amenable to local therapy, patient should be offered induction. Is not amenable to local therapy, should be offered induction chemotherapy before new evaluation of the local treatment. Both the treatments can be offered, and we should leave it up to the patient to decide. Maintenance immunotherapy in non-progressing patients with concurrent chemoradiotherapy has emerged as a new standard of care. This is just a diagram of, again, a recently published article just to simplify. This is the controversial N2. So we can see if it's potentially resectable and it's a single station and it's non-bulky, then surgery is preferred. If it is bulky, then RT is preferred. And if it is multi-station, then again, if it is non-bulky, surgery is preferred. But if it is multi-zone, then radiation is preferred. These authors have analyzed 10 guidelines. This is a very simplified diagram, but when we come to the next one, we can see that things get complicated. Even in stage 3 and 2, when it is single station and it is non-bulky, majority of the guidelines say no preference. So that means both are preference, because we do not have any randomized data to suggest that one local therapy is superior to another local therapy. If you look at the NICE guidelines, they're always preferring surgery. Here also surgery, here also surgery, everywhere surgery, surgery, and surgery. But again, if you go into the multi-zone single station, multi-station zone, again, we can see if it is non-bulky, still majority would prefer no preference. So again, both are preferences. And of course, if it is potentially not resectable, then we can be offered radiation. So they've again concluded that how do the majority of the guidelines say? So if it is a potentially resectable single lymph node and is non-bulky, 60% of the guidelines say that there's no preference. Both can be discussed with the patient. Also, there was no consensus when there was a lymph node and multi-station, and it was non-bulky. Again, there was no consensus. Majority of the consensus was that when surgery was not an option, so the guidelines have preferred radiation. So multidisciplinary delivery is very important, and everything is to be discussed in detail with the patient. So the multidisciplinary team should comprise of pathology, radiology, nuclear medicine, thoracic surgeon, radiation oncologist, medical oncologist, onco-anesthesia sitting as a one team. This is another interesting article published in BJC, which has told the current landscape of stage 3 cancers. So you can see that we are talking about 2 local therapies, but there will be a large subset of patients that will be just offered best supportive care, no local therapies because of the poor performance. Palliative intent, again, a lot of majority would be preferred. Only chemo would be preferred in majority of the patients. A small subset would be preferred for radical concurrent chemoradiotherapy. So it's very heterogeneous, and there are a lot of patient-related factors that are to be accounted. And you see the local therapies, we are talking about little patients who are very fit, and maybe the surgeon feels are good, but not everyone would be a candidate. And also there's recent data, landmark article by Temel et al. In NEGM, which says that early institution of palliative care improves survival. So that has also to be kept in the mind. So my conclusion from my stage is that stage 3 is a very heterogeneous subset with very variable prognosis. Option of local therapy include CRT, surgery, RT, and none also, depending on the performance status and tolerance. Neoadjuvant CRT has role in superior sulcus tumor. Other than this, should not be routinely offered because there's no added advantage. After neoadjuvant therapy, lobectomy is associated with better outcomes than pneumonectomy. This is a subset analysis of the landmark trials that we discussed. In an unresectable tumor, CRT is the standard of care. And if one is subjecting to neoadjuvant, then the local therapies can be discussed and should be left up to the patient's preference. All patients should be conjointly discussed in MDT to provide the best treatment option tailored to each patient, depending upon age and stage. We know from T1 to T4 and N also, like N2 is very controversial and it has a lot of subsets into it. And also patients' performance status, pulmonary function test, and presence of comorbidity should be discussed in detail so that the best patients are given the best options. This is just just like the surgical skills.
Dr. Aman, I think time is over. Sorry to interrupt you.
That's fine. We just did an SBRT, a big 5 centimeters lymph node mass and a big 5 centimeters tumors. So this is the first time that in the world somebody had tried SBRT in a stage 3 lung cancers, and we have interesting results. The patient is disease free. Thank you.
So thank you. Thank you for the excellent presentation. I think questions we can take during lunch. I know everyone has questions in their mind. So thank you so much. And it's my honor to invite Professor Sunil Kumar, my teacher, and he'll be speaking on complications following minimal invasive thoracic surgery. So hand over to Professor Dr. Sunil Kumar, sir, for the next talk. Okay.
I think some miscommunication. The topic is challenges in thoracic surgery in India. Only 10. Yeah. 10. Make it fine. Thank you very much. I am the last one. You have to bear with me. And also, let me clarify, this talk is not directed towards seniors. They had their own share of experience and their own wisdom we have been getting for last 3 days. This is more towards people who are going to venture into thoracic surgery field as an early career or beginner. I'm going to talk about what we have faced through. We had a transition time during our establishment of the program, and what you are going to face in a similar way to some extent. But at the same time, whenever there is a challenge, you have a will to resolve it, and then there you find the opportunity. So how much you can find that? It's your innovation and it's your imagination. So lung cancer is the most common cause of mortality that is world over. That is true. So that's number one. So that's a big burden. At the same time, second part of the thoracic surgery, that is esophageal cancer, that is the most common GI malignancy. But things are not ending here. You have to cover 3 more things: mediastinal tumor, chest wall tumor, and pulmonary metastasis. So you have a comprehensive range of things to do. And for all of them, surgery is the primary treatment. So here are some of the numbers if you are interested. More than 100,000 patients of lung cancer in 2020. More than 50,000 patients of esophageal cancer in 2020. So you have enough to do. And you have, your hands are full. There are not many people to do so. Do it. But good thing is that what was considered earlier a taboo or a morbid kind of procedure, morbid kind of surgery is in the domain of a safer surgery. Safety, safety, safety. That's what you heard from Diego as well in the last talk. But important is that how to make the things safer, that you have to be careful in better patient selection. Also, how to evaluate. Minimally invasive surgery has its own role, but that's not the panacea. You have to be clear that you have to accept a lot of patients who are probably not fit for that, but within that group, you have to select. But better intensive care, better ICU care, anesthetic management, all these things, better pain management, all these things have contributed that it's just like any other surgery. We have huge numbers, true. But the problem is here that most of the time you are having advanced patients. And you take 10 patients, probably one, if you are lucky, one will be suitable for upfront. There gives you another opportunity. So locally advanced group is 30%, and two people were trying to either make our life easier or difficult. It's your judgment to bring them into surgical domain or take them out of surgical domain. So many of them are resectable, but inoperable because of the existent problem, whether in the form of COPD or because of the background of tuberculosis, but it's risky. So there is grossly an unmet need for this facility personnel. Very few dedicated teams are there who are giving comprehensive thoracic care. There are teams who are specialized in lung cancer. There are teams who are specialized in esophageal cancer. There are teams who are good, to some extent doing a comprehensive work. So there is a huge gap between what is required and what is available in the country in terms of the service. Not I'm talking about in terms of individual. So particularly if you see the COVID era, then a lot of patients underwent CT scan and some small nodules were detected. All these patients were very, very early disease and they were incidentally detected. That has thrown a big opportunity for all the thoracic surgeons, particularly lung cancer patients, that there you have straightforward cases and you can start any of them. So that's where the increasing role of surgery, new dimension or new addition to the indication. Then the problem comes, then the next challenge is that most of the programs are either cardiac or maybe to some extent thoracic, 95%, 5%. And that's an unwritten division. Whether these are mutually exclusive, particularly if you take malignancies also, so the cardiac surgeon will not be doing lung cancer or esophageal cancer. Other way around is definitely true. But similarly, one more handicap is that the exposure to the vascular surgery. It's not everybody ball game to catch that bleeding pulmonary artery. You have to have a good vascular surgery exposure. So unless you make your program comprehensive, which encompasses all the 5 domains, then again, the handicap is going to be there. And there comes that how to make it more comprehensive, because you come across another challenge, that is training of the professional. So how many programs are there in India who are dealing or giving exclusive thoracic surgery training? I'll come to that also. There, how much exposure you are having, whether you are dealing only with esophagus or you are dealing with only lungs or maybe a little bit up to some extent, but not at the top notch. And then certainly there is a lack of cardiac surgery exposure, which is an integral portion, particularly if you venture into mediastinum. Bronchoscopy and endoscopy intervention. The surgeons should be equally competent and comfortable with this. So these are the only 3 programs. If you see the DNB checklist for there are some fellowship programs, but these are the 3-year DNB programs and in the name of so-called dedicated thoracic surgery training. Then comes the financial problem, that all these surgeries are costly, no doubt about that. You saw yesterday, stapler, 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 fire, fire, fire. But there are government schemes nowadays available and you can find your opportunity there, then how to make. And at the same time, you have to innovate where to cut down the cost. Because unless these 2 things are combined, probably again, you will be scared of, oh, so costly surgery. Let's not do that. So more and more the services are decentralized, disseminated, then only the cost reduction will be there. If it's the volume game, the volume goes up, the cost goes down. So like I said, less than 10% of the patients are, maybe 5% of the patients are in the surgical domain. So how to increase that pool? There comes the role of neoadjuvant treatment. Whether it's through chemotherapy, immunotherapy, We have to accept that. Prabhat said that you can't escape, patients who are coming after receiving immunotherapy. Good, they will be coming at least. That is more important. So you have to be prepared. Early detection, again, don't leave that. So because there is a increasing awareness among the physicians also, it's not the situation that everybody is receiving 6 months of ATT and then they are coming to you because everything is progressed. We had our own share of experience about how effective neoadjuvant treatment is there for these patients. And our program is something around 40% of the neoadjuvant, 60% of the upfront, which is quite a big bulk. Then the problem is of treatment planning, that we do not have consistent and uniform treatment planning or treatment protocol. We are just following. And treatment arms are different, centers are different. So you enter through which gate, you will get that kind of treatment. It all depends on that, literally or practically, that's the situation. So what is needed is comprehensive care plan. So multidisciplinary management, that is must. So whenever you are going to venture into that, you have to think about that, establish that part. Unless you have a strong support from anesthesia team, the pulmonary team, ICU team, forget about this. So even if you are doing a smaller scale surgery, but these components cannot be done away with. So treatment policy, again, either you have evidence-based medicine or maybe experience-based medicine, but ultimately some combination has to be there. Following the guidelines is fine, but unless you are aware about their context and their setting, blindly emulating them is not going to help you much. And there comes the opportunity for professional societies that if they are willing to take a lead for that in Indian context, what we need is the tailor-made treatment policy. That's the reason. And that will be coming through some data. Unless you have the data, you cannot, formulate your policy, you cannot formulate your experience. So a lot of work is being done, but where is the documentation? So we are losing the precious data, essentially directed towards safety and the outcome. That's not clear. A lot of people are doing, but then it has to be pooled. Unless we go for institutional data pooling, you will not have the overall country-wise picture. The National Cancer Registry has taken a lead in that, and I hope that that will clear the picture on a national scale, maybe up to some extent, but yes, at least some beginning has. Because there are certain variations. If you say the, use of ALK inhibitor blindly, in the West, it's going to be 10%, in India, it's 27%, and if you go to Japan, it's going to be 35%. So there is a variation in that. We always say that numbers are our strength, but that is true. But what is the catch in that? There has to be a strong need for converting, those numbers into power. It should be in an organized fashion. Then only it will make sense. Otherwise, it's just a collection of haphazard numbers. So for that, you need to have institutional database, and that's a must. Whatever you are doing, keep a data for that and document that, keep the data archive. It may be a small, but if it's organized, it's going to be meaningful, and it will be in a position to be collated and make a bigger data for that. So you can go through this article, which came just, 13th of February, just 2 weeks back. So this is something, if you want to have a look at that, this is where we are sharing our experience, because we always, had a very big premium on that, and that's what our experience. So finally, what are the challenges in starting a program? You learn lobectomy, you learn segmentectomy, fine, but that's not the end of the day. That is not sufficient. Operating infrastructure, that is one component of that, but more important is that to put into pieces, all the pieces together in the form of a comprehensive program. You need surgeons, you need anesthetists, you need trained nursing personnel, otherwise everybody will be working in highly asynchronous manner. Safety targets, that is the premium, and that is the primary point for your program where it's heading. Unless you have an audit about that, just doing it not good enough. And in the end, so there is a massive demand supply gap, and that throws massive opportunities also. It's up to you that how capable you are to encast that in your favor. Challenges are always there, they will be there, and they are there. It's still multiple, but within that, we have to find opportunities also. Start small, but be organized. Take baby step one by one. Don't go for a big bang, rather go for an incremental growth, addition bit by bit. Sky is the limit. Do whatever you want. Impossible is nothing. You have been hearing for last 3 days, but there is a rider behind that. And what is that? There is a huge hard work and dedication behind that. There is no shortcut. Thank you very much. I hope there are no questions.
Any questions from the audience, please? Regarding thoracic surgical programs, Dr. Sunil, what should be the way forward? So we have the 3 streams coming: the cardiothoracic, the general surgery, and surgical oncology, depending on the need. Would you recommend a joint hybrid program sort of catering to the entire thoracic surgery, or there should be a dedicated oncology?
So it all depends on the work profile and the requirement of the center, number one. At the end of the day, you are providing your services. We are not doing only for the sake of our own place. But where you are working, what is the requirement? If the requirement is that there are a lot of cancer patients, probably your hands will be full in that. But it's always ideal, and it will always better that the program should be comprehensive. Whether it's the mix of benign and malignant, fine. There is always an opportunity to choose from that. But if the team is comprehensive, there is always a better possibility of providing a comprehensive care. So ideally speaking, yes, and that should include not only general surgery, but cardiac surgery team as well.
What I'm actually scared, not related to this, is the incidence is definitely on the highest side, the trends which are showing. And surgeons are relatively able to handle, because most of them are inoperable or locally advanced. But with the kind of awareness and the imaging coming into field, it is going to explode the surgical load in the next 5 years. That's what I'm really worried. We need to strengthen the training programs. If that happens, I think it's going to be a tipping point for surgeons.
We are way below what is required, and programs like these, they are just small efforts to at least put them on the path, to pick it up. You may be doing maybe X, Y, Z other work also, but if the thoracic is the primary thing, please.
Sir,
Last question, please.
Last question, yeah, no problem. See, when I was doing thoracic, not many people are interested. Everybody was telling, put me in GI. And I said, okay, nobody's going, I'll go. It is the responsibility of leaders like you, sir, and Dr. Dev to create that need and the passion among the younger generation. So if somebody feels that, okay, Dr. Sunil is going to establish such a fantastic program in the country, so many people will buy. I saw so many people now who are coming and asking, sir, can we come and join a place like this? And is there a vision for a place like this? Such a beautiful campus, such a good infrastructure, and the motivation to do more. I think this will become one of the most pioneering centers for thoracic oncology in the.
Thank you very much, sir.
So we are planning to, it's too preliminary to say that, but that is our motive, that this program is going to be in the frequency of annual. So every year we will have.
And we are also, I think, submitted a proposal by Dr. Sunil for thoracic oncology fellowship.
Yes.
After MCH, 2 years dedicated. It's under consideration by Dean's Committee. Hopefully by next year, we should be able to start the program. Madhav?
Yeah, my point's also same thing. When we started in ISCH, initially it is any institute is difficult, definitely. But the person, the leader, like Sarvan is telling, one has to take the idea, leave it, and push it type things. So anyway, like we started in Bhubaneswar. So I was interested in thoracic. We are taking into next level now. If you'll see, that is a referral center of all East. So what are you telling? This is it will not take the next level. You have to like comprehensive training system. Like sir is telling, after the establish basic thing, then you will go for the like everyone is not surgical oncology MCS. Then during that training period, how you will push your residents, and next level you can go for like the fellowship program. Otherwise, once upon a time I am interested, I will do the thoracic, and it is not like that. You have to make in fact like the coordinating with the thoracic surgeons, and every center has not a good thoracic surgeons. So like a pulmonary medicine, pulmonologist,
medical oncologists. You need a whole team. And IRCH were the best example that we have been trained endoscopists, like bronchoscopy, endoscopy. This should be an integral part of the surgical oncology training system. And we are trying to also do same thing in all AIMS. That is the best model. That is the things. I don't know about the TMS, but but that is not possible also everywhere. If you are having a good coordination among like pulmonologists, medical oncologists, radiation oncologists, and thoracic surgeons, this will be better program.
I would like to address, since I started my career in thoracic in 2004, I was lucky enough to enter a cardiac transplant and thoracic units at early. And till that time, there was no picture of thoracic surgery in ISCTS nor any other platform. And I had to roam across the country to take cardiac, thoracic, surgical oncology experience and to become to this level where any vascular problem occurs, we can do it. So AIMS is a good platform, probably where all the big people are there and the established departments are there, where a comprehensive program in thoracic oncology can bird up and become a big name in its whole over the country, where candidates can rotate among in cardiac, vascular, as well as surgical oncology and a dedicated thoracic oncology where MDTs are taking place on a regular interval. And it will emerge as a long range program where the candidates will have a future in thoracic oncology specialization. Thank you.
Thank you very much, Sunil sir. I think with this we can conclude this session.
Now I request Professor Madhavanand and Professor Sushma Bhatnagar to felicitate the chairpersons. Dr. Ashish, Dr. Sanjeev Kumar, Dr. Prashant Gupta, and Dr. Prabhat Malik. Thank you, Sarah ma'am. There's a small announcement. Bus services for delegates starts from H3 apartment at 2 p.m. It goes through airport to Delhi. And another is participants can collect their certificates from registration counter. Next session is oral presentation. Yesterday we had 14 fantastic poster presentations. From that, judges selected 6 for podium presentation today. The first 6 oral presentations for award category Followed by there is a non-award category. There are only 3 presenters are there. Because of logistic reasons, they could not present yesterday, the abstract presentation. So they will present today here in podium. Instruction for oral presentation is 5 minutes presentation followed by 1 minute discussion. Judges for today's oral presentation, Dr. Saravana Rajamanikyam, Dr. Bhushan Tambore, Dr. Siddharth Hazarika. Prices for award category. First prize is rupees 10,000. Second and third prizes are rupees 5,000 each. First presenter, Dr. Dibya Chodi Deka. Presentation is for 5 minutes and 1 minute for discussion. Please keep the time.
A very good afternoon to all. I myself, Dr. Dibya Deka. I am an MCS resident from B. Bora Cancer Institute, Guwahati. I'm here to share my early experience with video-assisted thoracoscopic surgery in pulmonary metastatic in a tertiary care center in Northeast India. Coming to the methods and materials, in this study, a patient who underwent VATS pulmonary metastectomy between June 2022 to January 2023 at B. Bora Cancer Institute were analyzed retrospectively. VATS metastectomy were done by uniportal technique. To look for any complication, we did the HRCT thorax and post-op day 3 for all the patients. Now coming to the results table, here you can see the age group was between 12 to 54 years. Primary diagnosis in 3 were osteosarcoma and 1 was rhabdomyosarcoma or well peripheral soft tissue sarcomas. The average hospital stay was 4.5 days. The mean operative duration was 48 minutes. Here you can see the operative time. In 1 cases, we have done bilateral nodules and the rest of the 3 were single nodules. All these nodules were peripheral nodules. The ICD duration was 3 days, 2 days, 2 days, and 3 days. There are no lung complication in the patients except for 1. The patient with rhabdomyosarcoma, he had subfolio grade 1 leak, which subsided subsequently without any intervention. Now coming to the post-op HP, in 3 cases, the post-op margins were free. All were more than 10 mm. According to the study, the safety margin for pulmonary metastatic is 10 mm is sufficient. Now coming to the visual analog score for pain, the average score was 3 at 48 hours post-op period with oral analgesics. Here is a photo gallery where you can see a peripheral soft tissue nodule in the lung. We did the pulmonary metastasis in a hybrid technique. Actually, we used incision of around 4 centimeter and we used a medium sized wound protector. We have taken down the lung with the double lumen tube. Then generally in VAS we don't have the tactile sensation, we don't touch it, but we did this technique in a hybrid technique because we don't have the ICG backup or we didn't mark it with methylene blue preoperatively. So after we take down the lung, we just pull it out when palpate the nodules. So we are now restricted to doing only peripheral nodules by these techniques. In a study by Riyad et al., the average hospital stay for open thoracotomy was 6.4 days. In our series, it was much lower, although it is a very small series of 4 cases. In another study by DMEAC, the average operative time for pulmonary metastatic open pulmonary metastasis was 84 minutes. In our series, it was 48 minutes. But this will be not good comparison because they did for multiple nodules and we are doing it for a single nodule. So coming to a conclusion, VATS is a safe approach for pulmonary metastasis in patient with pulmonary metastasis. Thank you.
A very excellent presentation. You finished on time. So very important for next speakers. If you finish on time, we can ask you questions. So if you come up to questions, it will be very good. So my first question is, from your initial experience, when you will not do a VATS metastatectomy?
Sir, you will not do if the primary disease is not controlled firstly. So you are asking for any metastasis?
No, for VATS metastasis. So you're comparing VATS and open, right?
So if it is a deep-seated, sir, then we will not go for VATS metastasis. Because here we are, if you are not going for lobectomy, you are going for wedge resection, which will be difficult for deep-seated lesions. Sir.
What? Technical. You said deep-seated. Number?
Sir. Yes, sir. Multiple nodules.
What is the number? Beyond which, do you know of any paper which says beyond a certain number, it's not safe to do VATS?
Sorry, sir. Don't have the number.
No, there is a paper. So I just
Sorry, sir. I don't know the numbers.
Okay. Okay, last question is, when you're doing bilateral, what you should be very cautious about? So in your patient,
yes,
the bilateral case was a osteo or a rhabdo?
Osteosarcoma.
Okay, so
I'm not getting the question, sir.
No.
About the patient profile you
Yeah,
are
when-
asking, sir?
No, when you're doing bilateral metastaectomy,
Yes, sir.
especially when you're doing VATS,
Yes.
you should be very careful about what in the post-op complications, what you should be very careful about.
We need aggressive spirometry and also that we don't develop post-op atelectasia, sir.
Yes, you have to do very good prehabilitation whenever you're doing bilateral, because sometimes just the VATS incision also causes the patient to have so much pain they can't breathe.
Because of pain, they don't breathe and
Yeah,
they
yeah.
go
So
for
you have to be very, you have to inform them well and be
We
very
have
careful
a
when you're doing
dedicated
bilateral.
physio teams are there who regularly visit the ICU twice a day. Coordinate accordingly.
Yeah, you can do staged. Suppose many times you see that when you palpate, you can't palpate. What will you do?
We can go, if we have technological backup, we can go for ICG, sir. Or if the lesion is very small, then we can preoperatively, we can do CT guided methylene blue localization, sir. Or sometime we can even do localization with part localizer which are we using in breast, we can use.
No, Dr. Sarvana is asking intraop, what will you do? If you have taken the case, you have opened up and you have put your camera and you are trying to localize it, you put your finger, try to palpate, you put the lung here and there.
If the incision is big enough, say 5 centimeter, we can say use a USG probe also. Intraoperative.
Any other techniques you can think about intraop, innovative?
No. Thank you, sir.
Yes, nice. Thank you, President.
Next presenter, Dr. Harish Marana.
Good morning, respected faculties and delegates. I am Dr. Harish Marana. I am an MCH trainee in the Department of Surgical Oncology at IRCH AIIMS under the guidance of Dr. SVS Dio sir and Dr. Sunil. So I'm here to present a paper on minimally invasive versus open esophagectomy in Indian patients. Topic is it better to PEEP or to barge in? Introduction. Esophagectomy procedures are complex and challenging surgeries associated with very high morbidity. To circumvent this, minimally invasive and hybrid approaches have emerged to improve the perioperative outcomes. Our aims and objectives were to compare and share our experience on oncological outcomes and post-operative morbidities with minimally invasive and open esophagectomy procedures. The methodology, it was an retrospective audit of a prospectively maintained database on esophageal cancer from Jan 2017 to May 2022 at our department at IRCH AIIMS Delhi. All the cases from the cases which we had taken, a propensity matching score was done to compare minimally invasive esophagectomy patients with matched control from open surgery group. Stratification analysis using Strata software was done. Coming to the results, a total of 194 patients were planned for surgery, out of which 158 patients underwent curative resection. In those, 67 patients underwent minimally invasive surgery and 91 patients underwent open surgery. Coming to the demographics of that, you see the age and the tumor location was similar, slightly higher in the lower esophageal groups in both arms, both groups. And we had a higher rates of squamous cell carcinoma over adenocarcinoma with approximately 80% in both groups. And majority of our patients received neoadjuvant treatment, either NACT or NACT-RT, followed by surgery. And coming to the parameters, if you see the mean operative time, it was slightly higher in the minimally invasive group, 428 minutes compared to 382 minutes, which was statistically significant. However, the mean blood loss, blood transfusion, ICU stay, hospital stay, and the number of lymph nodes harvested were all similar in both groups. The other results, the anastomotic leak rates, the hoarseness of voice, the pleural post-operative pleural effusion and chyle leak were similar in both groups, statistically not significant. The intraoperative conversion rates to open was 14.6%. You see the post-op complications, grade 1 complications were 43 and 70 number. Grade 3-4 complications were 3 and 4. And re-exploration was 3 in the lab group and 4 in the open group. Hoarseness of voice were 2 in both groups, both were in MECU1 surgery. All were not statistically significant. The surgical re-exploration was done in 3 patients in MIS and 4 patients in group. The overall the mean disease-free survival was 30.6 months in the minimal invasive group as compared to 33.2 months in the open group, which was also similar. What I would like to conclude based on this study is that a minimally invasive esophagectomy has similar oncological outcomes and perioperative morbidity when compared with open esophagectomy. Only the drawback was the slightly higher duration of operative time. Thank you.
You have not compared the short-term benefits with MIS versus open. Have you shown that? Short-term benefits. What are the short-term difference, like your pneumonia, the pneumonia complications and your pain? Have you presented
With
that?
respect to the immediate perioperative morbidities, both were similar in terms of atelectasis pneumonia and pleural effusion. And the duration of hospital stay was also similar in both groups, and ICU stay.
Harish, go to your complication slide.
Yes.
Next slide. See, Harish, when we're doing open versus minimally invasive, see, all the complications you have mentioned over here have no relation to the approach. See, pleural effusion, no relation to the approach. Anastomotic leak, no relation to approach. Hoarseness of noise, no relation to approach. Chyle leak, no relation to approach. So what do you think is the main difference between a minimal access and a? So one is incision, wound complication is probably one. Second is pulmonary complication. Everywhere they say that the pulmonary complication is much less. So I know you would have mentioned that grade 1 complication is 4370. I think those 2 parameters are the main factors which need to be, because that is focused on the approach. That is the main difference, right? Yes, or no? So
Yes.
I want to know pulmonary complications like pneumonitis, patches, pneumonia, ICU stay, that should have been mentioned here. It would have been no difference, right? But
yes,
it should have been mentioned in the thing. Others all are no, there's no relation between the approaches, because anastomosis you're going to do anyway the same, whether you're doing MIS or You get my point?
Yes, sir.
Okay. Otherwise, I would commend you that the data, what you have got, the database that you are having, 194 patients propensitively matched is a very good effort that you have taken. But then, yes, you need to mention these things for specific reasons that the complications are less. That is why we go. Operative time, it's subjective. You may be very good in a very good open surgeon, but you are very slow. So I think those things are very important.
Learning curve is also there.
Learning curve is there, so all those things are there. But the complications, yes, you could have made it a little better.
Yes, sir.
Otherwise, an excellent presentation. So when you go finish your MCH, okay, when you go to your practice, what is your opinion? What will you choose?
But if the patient is fit enough, I will definitely go for minimally invasive.
Fit enough, minimally invasive.
Patient
is not fit, then open.
If I have the facility available, I will definitely always go for minimally invasive.
So that should be the answer, because a little less fit patient, better to do minimal access, right? Then open. Okay.
Thank you, sir.
Thank you. Thank you. Good.
Next presenter is Dr. Neha Shelikeri.
Good morning. I'm Neha Shalikeri from AIMS Jodhpur, and I'm here to present our initial experience of robotic-assisted minimally invasive esophageectomy from our institute under the able guidance of Dr. Jeevan Ram Vishnoi. So esophageal malignancies presents a significant cancer burden, not only in terms of both incidence as well as cancer-related mortality, and surgery is an integral part of the treatment process. Surgery is challenging, one, because anatomically, esophagus spans two different compartments, thoracic as well as abdomen, and the lymph nodes have to be dealt with in both the compartments. The access in the thorax is a important factor, as well as since the esophagus is nested within proximity to very critical structures, intrathoracic dissection also is extremely challenging. So minimally invasive techniques for esophageal resection have been designed way back from 1992 and they continue to be investigated in various aspects in order to reduce morbidity as well as mortality while trying to achieve oncological outcomes, which are equivalent. So our study aims to report technical details and preliminary outcomes of McEwen's robotic assisted minimally invasive esophageectomy using stapled esophagogastric anastomosis. It is a single institute, a single surgeon retrospective observational study, which was done on a prospectively maintained data of computerized records as well as video records. It was conducted from May 2018 to December 2022 with a total of 42 patients who underwent surgery with either neoadjuvant chemotherapy or radiotherapy previously received. The procedure was performed in 3 phases. Thoracic phase using the robot, abdominal phase either robotic or open, and cervical anastomosis with linear stapler technique side-to-side anastomosis. Important parameters that were studied were total operative time, total blood loss, total hospital stay, number of lymph nodes retrieved, and anastomotic leak rate and 30-day mortality rate. The port placement is as follows. There are a couple of pictures that we would want to show. One is the thoracic phase dissection of the esophagus. In the second picture, we can see the azygous vein being staple ligated. And the third picture is the lymph node retrieval along the recurrent laryngeal nerve. The conduit preparation was done using a hybrid technique with a wound protector and the conduit brought out. One of these patients who had a metallic stent in situ previously. A couple of cases, about 4 to 5 cases, we've done total robotic where the entire conduit was prepared robotically and the specimen was delivered through the neck. Finally, these two last pictures which depict the esophagogastric anastomosis in the neck using staples. This is the final image and the specimen. So the results, we studied a total of 42 patients with a median age of 54 years, male and female 20 and 22 respectively. Most of our cases were squamous cell carcinoma and mid-third. And apart from 2 patients which were taken upfront, most of them received neoadjuvant therapy, mostly neoadjuvant chemotherapy, and 5 of them received RT as well. So the primary parameters studied were total operative time, which was 400 minutes, about 6.8 hours on an average, and thoracic phase of 2.7 hours. Blood loss was around 245 ml. Total hospital stay was around 11 days. And 30-day mortality in our study was nil. Number of lymph nodes retrieved was around 22, ranging from 17 to 64. So high lymph node yield significantly increases survival, which is depicted in various studies done previously after esophagectomy. Clearing lymph nodes along the recurrent laryngeal nerve is necessary for better survival. And lymphadenectomy along recurrent laryngeal nerve in a minimally invasive procedure does not increase the incidence of recurrent laryngeal nerve palsy. An optimum lymph node clearance along with margin negative status is important. In our study, we had 8 patients with postoperative complications, none with major anastomotic leak, no postoperative mortality, 1 chylic that required thoracoscopic duct ligation, 1 minor anastomotic leak managed conservatively, 1 superficial wound infection, 2 atelectasis, and 1 pneumothorax. 2 of the patients had recurrent laryngeal nerve palsy, 1 whose symptoms completely disappeared at the end of discharge, at the time of discharge, while other had persistent symptoms. And modified abdominal phase, we used a wound protector, which reduced our operating time. To conclude, robotic McEvans with side-to-side esophagogastric stapled anastomosis has excellent early postoperative outcomes, and it can facilitate adequate mediastinal lymphadenectomy without significantly increasing the morbidity related to pulmonary complications. Thank you.
That was a nice presentation, finished exactly in time. Any information on ICU stay duration?
Sir, most of our patients were shifted to post-op recovery room and to ward. About nearly 40% patients went to post-operative ICU, but only for a day.
Doctor, were you part of any of these procedures?
Yes, sir. From
how many of them?
Sir, about 19 to 20.
19 to 20. Okay. Now, which nerve do you think? How many nerve palsies you had? RLN.
Sir, we had 2, sir.
Which nerve?
Recurrent laryngeal.
Right or left?
Sir, right.
Are you sure? If you don't know to say, don't know. It's okay. Why I wanted to ask you is, and why I asked you whether you're part of this surgery. See, this is a feasibility study.
Yes, sir.
So that means you're actually telling the world that it is safe to do
Yes,
the
sir.
surgery. And
Yes.
you have to tell us why. One important fact is you have told that the lymph node dissection
Yes, sir.
is much easier when you do by robotic technique. Hands down, definitely. Every one of us who does robotic, we understand that lymph node dissection is also very important. And when you do lymph node dissection along the nerves,
yes, sir.
both right and the left, so which do you think in your mind will be the most to be affected, even if you do in robotics or open? Okay, so this is one thing. Just go back, find out which nerve was affected.
Yes, sir.
The second question I wanted to ask you was, how do you see in the future? No, the robot is expensive.
Yes, sir.
VATS is easy to do. It's easy for hospitals to establish. How do you see people choose between a robotics and a VATS versus open?
Sir,
This is just to see how much you understand, as the future and all those things.
Yes, sir. Sir, from surgeon's perspective and from patient's perspective, sir. From surgeon's perspective, the dissection is much more easier in terms of availability of 3D view and 10 times magnification and your degree of freedom of movement and the accessibility right from the hiatus right up to level 4, level 2 lymph nodes in the thorax. So surgeon's point of view, that is there. And patient's point of view, in central institutes where actually in big institutes where robots are available, most of it is covered under some sort of a scheme. Even under us, I think except for 2 patients, everyone has been operated under the scheme. And the only part where we charge is staples, endostaplers, where 60 endostaplers itself. So if the patient is able to afford at least that particular minimal amount, then most of them should be able to opt for robotic.
But he's asking about the private setup. He's asking any setup.
So I was asking, will you choose? So robot makes it easier if you're doing more difficult cases. So you
Yes,
would,
sir.
you
Given
would-
all the facilities in ideal situations, I would choose.
So Iverlose. So I wanted you to tell us. See, in Iverlose is extremely difficult to do VATS. People who are very much trained only do a VATS. Most of them do open Iverlose. So I wanted that answer from you that, okay, if it was an Iverlose, we would prefer robotic because it makes the surgery
Thoracic part much easier.
much easier. Okay, very good. Thank you.
Thank you, sir.
Next presenter is Dr. Pawan Kumar.
Morning, everyone. I'm Pawan Kumar, Senior Resident, Department Surgical Oncology in Bhubaneswar. Today I'm presenting my study on factors predicting the perioperative outcomes in video-assisted thoracoscopic thymectomy. As we all know, thymectomy is a mainstay of treatment in patients with a myasthenia gravis and thymic neoplasms. But the main issue with the thymectomy in patients with myasthenia gravis was the perioperative complications, and that too in the transcranial thymectomy. And minimal invasive thymectomies have been proven to reduce the postoperative morbidity. So here we are studying to identify the factors that predict the perioperative outcomes after VATS thymectomy. And the patient population was patients who had undergone VATS thymectomy from August 2016 to February 2023 were included. And inclusion criteria was patients with a generalized myasthenia gravis between 18 to 70 years of age, and patients with the thymic neoplasms. And exclusion criteria was patients not suitable for VATS approach, that too patient tumor size of less than 8 centimeter, and tumors which are invading the surrounding structures, and poor GC, and multiple uncontrolled comorbidities, and patients who are pregnant and lactating mothers. So patients were evaluated, and the disease severity in patients with myasthenia gravis, and the disease severity was graded according to the MGFA classification. And the clinical stabilization of the myasthenia gravis symptoms was done, and steroids were tapered to a minimal dose before surgery. And all thymic epithelial tumors were staged according to Masaoka staging. And patients were preoperatively optimized, and VATS thymectomy was done. And postoperatively, we observed for perioperative outcomes, we observed 2 things. One is postoperative complications and hospital stay. And hospital stay of more than 7 days, we consider it as a prolonged hospital stay. And also we observed the postoperative complications. The surgical technique, VATS extended thymectomy was in all patients, and mostly we done a right side approach, and patients with a large left sided tumors underwent bilateral approach. This is our port position in the partial left decubitus position, and 10 mm port at the 5th intercostal space in the midclavicular line, and another 10 mm port in the 5th intercostal space in the mid-axillary line, and 5 mm port in the 3rd intercostal space in the anterior axillary line. So this is the thymectomy specimen photographs. And hospital course, all the medications, including the cholinesterase inhibitors and the immunosuppressants, are continued postoperatively. Patients' postoperative course was documented, and complications were graded according to the calendar classification. And hospital stay more than 7 days considered as a prolonged hospital stay. And this is looking at the basic baseline characteristics of the patients. We are seeing that patients we had among the 38 patients we operated, 33 patients had a myasthenia gravis, and 5 patients didn't have a myasthenia gravis. And the most common indication for surgery was
patient with myasthenia gravis and also with thymoma. And around 30% of the patients had a history of myasthenic crisis, and around 54 patients had hospital admissions for myasthenia gravis issues before surgery. And so we have studied these factors with the perioperative outcomes after wax thymectomy, and we saw that patients with prolonged intubation, who requiring prolonged invasive ventilation, had a prolonged hospital stay, and patients with myasthenia gravis symptoms of more than 12 months before surgery had tended to have increased hospital stay, but it was not certainly significant. And one more thing is patients with MGFA class, severe MGFA class 3 or class 4, had tended to have increased hospital stay, but it was not statistically significant. It was a p-value of 0.07. And looking at the perioperative outcomes comparing to thymoma and non-thymoma patients, duration of surgery was higher in the patient with thymoma compared to non-thymoma group, and duration of invasive ventilation was prolonged in the thymoma group compared to non-thymoma group. However, this didn't turn into a post-operative or prolonged hospital stay or complications. Our analysis did not revealed any significant difference between the perioperative outcomes between thymoma and non-thymoma patients. And phrenic nerve palsy was observed in 4 patients, and all the patients had thymoma. My conclusion was post-operative myasthenic crisis was the most common complications we observed. It was found in 5.4 patients, that 2 patients among 38 patients. And patients with higher MGFA grades and disease duration of more than 12 months tended towards prolonged hospital stay. And the duration of invasive ventilation was an independent prognostic factor associated with the worst perioperative outcomes. And no significant difference in perioperative outcomes between thymoma and non-thymoma patients was seen. And however, the trend towards increased major complications was seen in the thymoma patients. Thank you.
A very extensive study. First thing I would like to say, you cannot compare ICU duration stay with thymoma without myasthenia gravis and thymoma with myasthenia gravis. Because with myasthenia gravis, definitely the stay will be longer. Yes. So were your myasthenia gravis patients optimized before the surgery?
Yes, sir. All the patients were optimized before surgery.
They were given immunoglobulin or plasmapheresis?
Sir, that is, sir, patients who required immunoglobulin and plasmapheresis, they had a history of myasthenia crisis before. They were optimized before, and the steroid dose the dose of steroids were minimal before surgery, and all the patients were optimized well, and after that only they were taken for surgery.
So you had some 5 patients myasthenia crisis.
Yes, sir. No,
So
sir. Post-operative myasthenia gravis, we had 2 patients. Sir.
2 patients. So were they given plasmapheresis before surgery?
Yes, sir. Both of the 2 patients had history of myasthenia crisis before, and they had received plasmapheresis before. Sir.
See, I think excellent work, whichever center you are from. I think you're from Bhubaneswar, right? Because it takes great teamwork to do such kind of work. Neurology, ICU, critical care, anesthesia, surgery, fantastic what you're presenting. And this although in the technical aspect of presentation, I think there are a little bit mistakes. With such small numbers, you can't compare and go to do univariate and multivariate. But I'll ask you one surgical. So again, another question. Were you washed up in any of these cases?
Sir, I washed in 3 or 4 patients, sir.
Okay, 3 or 4 patients. Okay. Why do you think the people had phrenic nerve palsy?
Sir, we had 4 phrenic nerve palsies, among which 3 patients had tumor on the left side. The tumor had left side, and all the patients with phrenic nerve palsy, they were actually phrenic nerve was actually either it was aborting or involved. It was not because of surgery. It was mainly because the tumor was invading the phrenic nerve. That was the main reason.
So, do you know that what does the ITMIC? There is a ITMIC guidelines for thymic resection in patient with thymic tumors and myasthenia. So, what does the ITMIC guidelines say if a patient with myasthenia gravis and a thymoma invading the phrenic nerve, should you resect or should you preserve? What does it say?
I'm not aware of the guidelines.
So read it. It's very important. You have to read it, and it's a message for you. You should know what the ITMIC guidelines say. Slowly, what we are seeing is the Meso-Koga staging is moving away. We are moving towards the TNM classification for thymic tumors. So the entire association of thymic malignancies, they all ask us to move away from a Meso-Koga staging. So I think you need to read up on that aspect also.
Yes.
Okay. Sure, when will you not do a minimal access thymic surgery?
Sir, when the tumor is actually, if it is thymic carcinoma, if it is a thymic tumor with invasion of the surrounding structure, major neurovascular structure, major vascular structure, and the tumor, if it is size of more than 8 centimeters, we actually go for an open approach, sir. Midline sternotomy.
Is there any other way to decrease pain? Because most nagging part is pulling the tumor out.
Yes, sir.
Do you know any alternative if for removing a large tumor?
Sir, we do mini thoracotomy incision was given. At least 6 centimeter of incision was given. So when it was not removed by the port, we had given incision up to 6 centimeters, sir. Mini thoracotomy incision.
Do you know
was
of
given.
any innovative? See, this will give you medal points. Any way where you can remove a large tumor through some other way? Because you saw the presentations by all experts. So you can remove large tumors by a
It can be put
subzified.
into a bag and can morcellation can be
Subzified.
done. Yes, sir, subzified.
Put your hand in and take it out. Less
Yes.
painful.
Yes. Thank you, sir.
Next presenter is Dr. Shivani Kapila.
Good afternoon, everyone. I'm Dr. Shivani Kapila, MCH trained in the Department of Surgical Oncology, IRCH in New Delhi. And I'll be presenting my study on pulmonary neuroendocrine tumors, surgico-pathological characterization and survival of patients treated at the tertiary level oncology center in India. Pulmonary neuroendocrine tumors are a heterogeneous group of malignancies and approximately constitute 2% of all lung malignancies. Rarity of these tumors limits available clinical data. Management principles are similar to the non-small cell lung cancer. We aim with this study to describe the surgico-pathological outcomes and survival after curative intent surgical resection of neuroendocrine tumors of the lung. We analyzed all patients treated with curative intent surgical resections, which was 70 in our database between 2006 and 2022. Our source was prospectively maintained structured lung cancer database. The patients were staged according to the 8th edition of the AJCC TNM staging system. We evaluated demographic features, surgical characteristics, pathological features, and survival outcomes. 70 patients were analyzed. The median age was 35 years, ranging from 14 to 65 years. There was a male preponderance. 48 out of 70 patients were male, which was 68.5%. When we come to the surgical resection profile, lobectomy was done in 25 patients, which was 36%. A bilobectomy was done in 19 patients, which was 27%. Pneumonectomy was done in 17 patients, which was 24%. A sleeve lobectomy in 5 patients, which was 7%. And sleeve resection only in 1.5%, which was a single patient. As for the distribution by stage, 56% patients were in stage 1, 36% in stage 2, and 8% in stage 3. As for the distribution by grade, typical carcinoids were found in 55 patients, which was a 78.5%. The majority of the patients were typical carcinoids. Atypical carcinoid was found in 14 patients, which was 20%. High-grade neuroendocrine tumors were found in 2 patients, and lymph nodes were involved in 3 patients, which was 4%. The patients had a median follow-up of 40 months. The median overall survival was 108 months. The median disease-free survival was 53 months. 6 patients developed recurrence, 3 out of which were in stage 2 and 3 were in stage 3, which was 8.5%. And 3 patients expired due to the disease. Majority of the patients developed distant recurrence and 1 patient had locoregional relapse. The 5-year overall survival rate was 100% for PT1 tumors, 96% for PT2 tumors, and 91% for PT3 tumors. When we compared the 5-year overall survival by grade of tumor, it was 97% for typical carcinoid, 91% for atypical carcinoid, and only 50% for high-grade neuroendocrine. With this study, we would like to conclude that when carcinoids present in a oncology center, a high frequency of them are typical carcinoids. And the 5-year overall survival for surgically resected tumors is high for early stage tumors and typical histology, while it is poorer for stage 3 disease and high-grade neuroendocrine tumors. Majority of the surgically resectable neuroendocrine tumors presenting at the tertiary level center are early age and favorable histologies. And surgical resection is limited to few cases in high-grade tumors and advanced stage. Thank you.
Excellent paper. First comment I will make is publish this fast. Okay, tomorrow you have to sit on your professor, publish it. Otherwise, we'll publish our data. Okay, because there's not much information. See, this is the value of maintaining a excellent prospective database in the hospital. Encourage all the education institutions over here, please maintain such database. You can get out so much information. Okay, my question over here is, you did not mention about lymph node status, surgical lymph node status.
Yes, sir. Actually,
So what is your philosophy in AIIMS, in your institution? For patients with carcinoid, do you do lymph nodes or you don't do?
So we don't routinely do lymph node dissections, but most of our patients present with visible enlarged lymph nodes. We do dissect, but they turn out to be negative for malignancy. They all turn out to be inflammatory or chronic inflammation or tuberculosis. But as a routine, we don't do lymph node dissection.
Second question. We have this problem a lot. Preoperative biopsy, NET, and then post low grade or typical or whatever, and then you do the surgery and then it comes as high grade or small cell. And then in the MDT, they ask us, why did you operate? Did you have such situations? Because I'm sure if you're maintaining a prospective database, there will be definitely one or two like this.
So till now, we have not had such a case.
Okay. Thank you. Nice presentation.
Thank you.
Next presenter is Dr. Siva Prakash.
A very good pleasant good morning, dignitaries. About myself, I'm Dr. Shiva Prakash, senior resident from Department of Surgical Oncology, Regional Cancer Center, Trivandrum. And I would also like to acknowledge my mentors, Dr. Chandramohan sir and Madhu Murali sir, before proceeding with my presentation. So this is regarding my presentation today is regarding our institutional experience in esophagus surgery, which is the most common oncological malignancy we deal about in our unit. So regarding a brief introduction about our unit, basically I'm doing residency in chest and GI services. It's a part of Department of Surgical Oncology, where we manage lung, CA esophagus and pulmonary medicine mediastinal tumors. Among this, CA esophagus and OG junction is the major chunk we deal with. So the primary aim of this paper is to analyze the pattern of esophageal surgeries ranging from open, hybrid, and minimally invasive approaches performed at our institute, and to analyze the early postoperative complications and mortality following the same. So the methodology is a retrospective study. It includes 53 patients in the time period of January 2021 to January 2023, roughly corresponding to my first year of residency to completion of my residency. So this is an experience of what I have encountered in my center. And regarding the analysis, what demographic treatment variables and very early postoperative complications based on Clavien into grade 2 and above, as 30-day mortality were analyzed. So in our institute of pattern of surgeries, it's an amateur institute where we have been doing open for a long time, and last 4 or 5 years we have been transforming into a minimally invasive center. And this graph, I think it's clearly demonstrating, even though open esophagectomy is the most commonly done in our center, and we are transforming into most minimally invasive esophagectomies coming. So regarding the numbers, I think the table is illustrative by itself. So regarding the results, it is just a preliminary analysis of what I have witnessed during my residency in minimally invasive esophagectomy. So my most of the patients were male patients, and regarding the early postoperative complications, before that, regarding the most commonly performed technique of esophagectomy, we are often with McEwan's esophagectomy, be it open or minimally invasive, and open McEwan's is the most commonly done at our institute, followed by open Iverlui esophagectomy. Regarding the complications, 21 out of 53, that is 1/3 of the patients had an early postoperative complication in our cohort. And as literature says, pulmonary complication was the most common thing we also have witnessed. regarding the surgical complication, there were 3 patients who had tile leak who were managed conservatively only, except 1 patient who required a thoracoscopic ligation of the thoracic duct, and 1 patient had anastomotic leak, which was managed conservatively. So the purpose of analyzing this is that any difference in early postoperative outcome that is favoring both the doctor and patient. The thing which I have analyzed is that there is a decrease in the average length of hospital stay. However, I have not looked into the mean ICU stay, but in our setup, there is not much difference between minimally invasive and open. Maybe a difference of a single day. And in our cohort, the 30-day mortality was absolutely nil. So regarding the complications, since it is a small volume, I couldn't prove any significance regarding the complication rate. Also, I have tabulated the most common complication based on grade 2 and above of clavia and endo. So to conclude, minimally invasive McEwan esophagectomy is the most commonly being done in our institute as a part of minimally invasive approach to esophagus, with negligible early adverse postoperative complication and a nil 30-day mortality. With the available data, I have proven a decreased hospital stay and decreased rate of reintervention. Thank you.
So, nice presentation. You mentioned regarding the MIS, you said there is less hospital stay, but you have mentioned it's the same stay.
Sir, I actually meant regarding ICUs.
And most of the surgeries are done completely minimally invasive, including abdomen part, or is
Yes,
it
sir.
hybrid?
Minimal invasive actually, complete minimally invasive or hybrid. Hybrid is very less actually. But when we are into minimal invasive, it is always fully
Convit
minimal.
also you're doing with the.
Yes, sir.
You're
Both
taking out a
abdomen and
specimen-
thoracic space.
specimen?
Anastomosis in the neck.
And
We
the
will open.
specimen you're taking out through?
Specimen through the neck. Yes.
Okay, now leak rate. How many leaks? You had 1 out of 53.
Yes.
Okay, now why do you think that RCC, we respect your professors, everybody, has such a low leak rate? Most of us have more leak rates.
Sir,
can you advise, guide us?
Sir, I'm too young to advise
No,
you.
but see, what is your observation?
Yes, sir. My observation as well as what you have discussed, same as a student I have discussed with the professors. The two things I observed from my mentors is one is standardization of technique. First. Second thing, and we have a strict protocol regarding initiating early oral feeds. Even though a lot of guidelines have come regarding early initiation following a thoracic anastomosis, we have a strict protocol of doing a contrast enema, non-contrast enema on post-op day 5. Make sure that it is not leaking. And also we have a, if at all there is a doubt, we don't hesitate in doing a scopy in early post-operative period. So this is what I felt and what I got from my mentors, that when you have a proper standardized protocol on place, your complications rate will be less. And I also abide what they say, and I like to follow the same.
Okay, now this is an important question that I want you to answer is, when you're doing Ivor Lewis, technical question, huh? So I want to know, minimal access Ivor Lewis, how do you do it?
Sir, first,
8 cases?
8 is opens. Till now, we
Oh.
have not done minimal invasive.
Oh.
Yes.
Ivor Lewis, you are doing end-to-end anastomosis or side to side?
End to sides.
End to side.
Yes.
Thank you. Thank you.
Thank you.
Award category got over. Now there are 3 presenters in non-award category. First presenter is Dr. Pratishtha.
Good afternoon, everyone. The title of my topic is Impact of Individualized in Patients Undergoing One Lung Ventilation, a Randomized Control Trial. I would like to thank Dr. Vinod sir for being chief guide of my study. As we know that the thoracic surgeries require one lung ventilation, and it is often associated with volutrauma, barotrauma, and biotrauma. That leads to the ventilator-induced lung injury, leading to post-operative pulmonary complications. Number of modalities like recruitment maneuvers and PEEP titration have been suggested over a period of years to reduce the incidence of ventilator-induced lung injury. But what is the ideal PEEP for any patient? As we know, there's a different demographic profile of the patient, plus the disease and the lung conditions vary in these patients. So one PEEP value cannot be good enough for all the patients. Thus came the concept of individualized. As we see here, once the patient is anesthetized in a lateral position, the functional residual capacity falls below the closing capacity, leading to the cyclical recruitment and de-recruitment of the lung. Once the PEEP is applied, FRC rise above the closing capacity, and with the low tidal volume, we can provide ideal conditions for ventilating these patients. The use of compliance has been suggested to provide good ventilatory efforts in these patients and to help identify the ideal PEEP in these patients. If we see here, there have been number of studies, and the results have been very confusing. As we see here, some studies have shown decrease in PPCs and better oxygenation, but number of studies have shown no significant difference. But the study protocol and was not uniform in all these studies. So with this knowledge, we performed the study. We performed the study with the aim to study the impact of alveolar recruitment followed by individualized PEEP on the oxygenation during and after one lung ventilation. Our primary objective was to see the change in oxygenation with intraoperative PEEP titration based on PF ratio, and secondary objectives were to identify the changes in ventilatory parameters, ABG parameters, and hemodynamic parameters. The patient who consented, aged more than 18 years, ASS state 1 to 3, and who were posted for elective thoracotomy surgeries with one lung ventilation were included. And these are some of the exclusion criteria. These included the patients with severe COPD. So two groups were made. One was control and other was individualized PEEP. In the control group, we saw that we selected a PEEP value of 5 centimeter that is quite commonly used both during one lung and both lung ventilation. But in the intervention group, during the one lung and the after one lung ventilation, once we reinitiated the total lung ventilation, patients were alveolar recruitment was done followed by PEEP type. For the alveolar recruitment maneuvers, PCV mode was selected. We started with the driving pressure of 20 centimeter water, rate of 15, and an I ratio of 1:1, and PEEP was 5 centimeter. We increased the PEEP by 5 centimeter every 5 breaths to maximum of 20 centimeter of water, followed by decremental PEEP trial, where PCV mode was changed to PCV. Tidal volume was 5 to 6 ml per kg, rate of 15, I ratio of 1:2, and we sequentially decreased the PEEP by 2 centimeter steps every 15 seconds. And we selected the PEEP best suited for that patients, which gave us the highest compliance, dynamic compliance in these. If you look at the results, the degree of oxygen, we studied the ABG at 5 time points, and we found that the change in oxygenation was best seen in the intervention group, and that too that was specifically from the time points before and after the one lung ventilation. But surprisingly, the increase in the oxygenation was not sustained in the subsequent time points. Even we followed the last time point was 24 hours after the surgery, and that was also found to be insignificant. The compliance were higher in the intervention group, and the ventilatory parameters PEEP was found to be 7.7 in the intervention group. And thus we conclude that there's a significant increase in oxygenation following lung recruitment and use of individualized PEEP intraoperatively, but it was not sustained in post-operative period. These two trials are undergoing that are going to look into the actual incidence of post-operative pulmonary complications. And these are my
How do you determine the individualized PEEP value?
In our monitors, anesthesia machine in the ventilators, it shows the dynamic compliance of the patient with breath to breath. So that we seeing that, and we were observing with each during the incremental and decremental, we were seeing that. Right.
Okay. Nice presentation. Any questions from man? Okay. Very nice study. Yeah, thank you.
Next presenter is Dr. Preeti Vijaykumaran.
A very good afternoon to everyone. At the very outset, I want to thank Professor Dio, Sunil sir, Naveen sir, and his team for giving me this opportunity to be present here and present my topic of discussion. I'm Dr. Preeti from Thoracic Surgery Services, Tata Memorial Hospital. And what I want to discuss today is the change in approach to lung cancer surgery that we have seen in TMH over the past decade, and also discuss regarding conversions in lung cancer. So as we all know, lung cancer is treated with multimodality approach, but surgery plays a very important role in primary management, upfront surgery, T1, T2, T3, N0, N1 lesions, and also post-neoadjuvant immuno or neoadjuvant chemoimmuno settings. And minimally invasive surgery is definitely the preferred approach, no question of doubt in that. What we have seen over the past 2 decades is that even though there was not much evidence in favor of MIS, just the common knowledge of a smaller incision, lesser pain, better recovery propelled towards MIS. Though the turning point I also see is the Violet trial, which showed significantly better functional outcome and quality of life. This is a retrospective analysis of all the thoracic cases, predominantly only NSCLC lung, which were treated with either upfront or post-neoadjuvant setting. After all the standard protocol, which is used in staging, mediastinal assessment, and functional evaluation. So we have operated about 1,260 patients over the last decade, 2012 to 22, out of which 64% of them were open, 36% were MIS approach, and VATS was 31% and robotic was only 5%. Predominantly, our reason is we have a shortage of availability of robot in terms of the chance that we get hands-on, financial reasons, because of which robotic is still in early stages. So this graph over here is showing the number of cases that we are doing in terms of VATS over the past years. And as we see, since 2016, there has been a continuous improvement in the number, except for the dip that was obviously because of the COVID. And the next graph is to show the percentage of cases. We prefer an open approach for pneumonectomy. So excluding those, lobectomies, sleeve, and bilobectomies, which we do by VATS approach, has also shown a improvement from 28% that was in 2012 to 50%, almost doubled in 2022. As far as conversion, it's not too low, not too high. We have an about 8% conversion rate in our VATS cases and have seen about 10% conversion where we're still in the learning curve in robotic cases. What I'm discussing here is only the VATS. So in VATS, most of our patients, about 40% of our lesions are central. And we're seeing about 15% of them T3, more than 5 centimeter lesions. And nodal burden is also quite high. And about 23% of them are post chemotherapy. That may explain why we have the significant conversion also. Most of the difficulties that we have faced is during the nodal dissection, fissural dissection due to adherent node post chemo setting, and obviously the tumor being bulky and having transfissural extension. So about 34% of our cases, there was bleeding, which was either related to node dissection injury or staple line bleed. Adherent nodal disease precluding a possible R0 was also a predominant reason. Others were transfissural extension, poorly formed fissures, additions where we still try our best to do VATS, but had to subsequently yield to an open approach in these 11.4% patients. So the conversion also was showing a trend. So I would request you to ignore the initial years where there was a significant learning curve and significant fluctuation. But after 2016, we are seeing a more or less stable conversion rate. This is in spite of all our younger faculties who are preferring to do a VATS approach. Robotic, we have done 62 cases, 6 conversions, 3 of them related to vascular clip slippage and vascular injury, others due to addition and nodes. The post-operative mortality was seen in 1 patient, not related to the surgical mortality though, and morbidity was seen in 64% of patients, which is significant. If you allow me to share this, I would like to play this video, which was of a left-sided surgery when we were trying to take the upper lobar vessels and had fired the stapler. There was error, technical glitch over here, and it led to significant bleeding, as you will see. This patient, we had to apply a compression and later go for a conversion. This was yet another case where during dissection of the upper lobar segment, probably the vessel underneath was pinched. Hence, it led to a bleed. But fortunately, with compression with gauze piece that came under control, and it gave us time to loop the vessel. And fortunately, the bleeding also got controlled. So what I want to present over here is that we are dealing, in our case, we are dealing with tumor size of about 5 centimeters. So our preference is to do VATS in properly selected patients. Our median tumor size is about 3.5 centimeter. With that and with more central tumors, nodal burden, we are able to do a good number of VATS cases with conversion rate, which is almost comparable with international standard. I would like to quote the JCO Cal GB paper, which was published in 2000, early 2000s, which was also showing a 10% conversion. And also the morbidity, that though this is not a proper statistical analysis, I would like to say that the morbidity of major Clavin-Dindo score was not much higher than what we see in our otherwise non-converted patients. So I pledge to promote minimally invasive approach in properly selected patients. And also this has helped me to understand the possible difficulties that would be faced during the surgery and what we will have to deal with in more precaution.
Yeah, nice presentation. I was also fortunate enough to be part of the same department in 2017 to 2018. At that time, Dr. George was had just started the journey of uniportal VATS, and probably Tata Memorial, the program is a like stage program, so the complications rates are lesser. Yeah, because the newer surgeon will be trained by the experienced surgeons, and they will be doing supervised, and then they will become experienced, and then the newer generation will be trained. So obviously that is a nice program, and the category of the patients coming to Tata Memorial are totally different.
Yes.
That's what they will be having tuberculosis, adhesions, and this thing. In spite for so many years, the same values and same statistics are remaining. Then I really appreciate.
Thank you, Nash.
Thank you, sir.
Next presenter is Dr. Pratik Maurya.
Okay, good afternoon, everyone. Myself, Dr. Pratik Maurya. I'm senior resident working at the Department of Onco-Anesthesia and Palliative Medicine. So today we are going to discuss the anesthesia topic, in which we will be discussing, we will be comparing two different methods, two different agents through which we can give anesthesia in thoracotomy patients who are supposed to undergo one lung ventilation. So in this study, we have compared desflurane versus sevoflurane as an inhalational agent, and we have noted certain parameters. So as we all know that one lung ventilation is a very high risk kind of ventilatory modality because it is prone to undergo hypoxemia. The patient is prone to undergo hypoxemia, acute lung injuries, and can face airway difficulties. Now there is a protective reflex in our body known as HPV, which divert blood from non-ventilated part of the lung to the ventilated part. So in past, a Cochrane review has been done regarding this, in which they have compared different anesthetic modality for the one lung ventilation. So our primary objective will be to compare the PaO2 at every 15 minutes till 60 minutes after initiation of one lung ventilation. And in the secondary objectives, we'll be also noting the different hemodynamic parameters and anesthetic variables during one lung ventilation. And the second secondary objective is that we'll be comparing the complication between the two agents. So this is how we started the study. It was a prospective randomized single-blinded study in which we have taken 63 patients, out of which there were certain dropouts. After the exclusion of the dropouts, we divided the patient into two groups, Group D and Group S. Group D received the desflurane and Group S received the sevoflurane. And then we compared the two groups and following data were analyzed like ABG, hemodynamic parameters, ventilatory parameters. Coming to results, this is the demographic table which shows that the two groups were comparable. We also noted the lab parameters and clinical parameters, and they were also found to be comparable. So this is a very important table in which we can see the PaO2 at different time in two different groups, Group D and Group S. As we can see, the baseline is almost same. Even the two lung ventilation, if we see, they are almost equivalent. It is just how the time progresses, the difference between the two inhalation agent gets more evident. If we talk about the complication, there was no any significant difference between the two groups. This is the graph of the PaO2. As you can see, as the time progresses, there's more evident difference between the two agents. So to conclude, both desflurane and sevoflurane are safe. Choice of anesthetic agent should be guided by patient-specific factor with not much difference in their ability to inhibit HPV or cause a change in arterial oxygen during initial 30 minutes of one lung ventilation. However, in surgeries requiring longer duration of one lung ventilation, greater than 30 minutes, desflurane may be associated with better arterial oxygenation. Both agents are not associated with any significant side effect or complication in cancer patient undergoing thoracotomy. So my concluding statement is this, that if both the agents are there, then and if the economy permits, we can go for the desflurane.
Thank you. Although we don't understand much, but just one question I want to ask. You say that desflurane and sevoflurane both have all similar things have come up in your results, but only recommending it for longer duration surgeries. Is there any difference between the prices?
Yes, sir. Desflurane is, it comes, the single vial comes around 8,000 rupees, and the sevoflurane, it comes roughly around 2,000 to 3,000, the single container.
So that matters for me, ma'am. That's it.
Any DLC values you had compared
No, sir.
before this thing? Because you are checking the arterial oxygenation, the diffusion capacity has to be included. Probably.
Yeah, we could. That's actually good
Have
idea.
you matched it with CPET values? With the
There
patient?
was a CPET. There's a CPET value in which we have included in the PAC that we have included.
Okay, thank you. Thank you.
Thank you. Thank you, Chairperson. I think we'll come to the end of this session. We have some small housekeeping announcements, then we are going to wind up the conference.
After this, there are dry lab sessions. Da Vinci hands-on simulation will be outside this building to the left, and surgical stimulation by Stupnik, it will be outside this auditorium, and also thoracic anesthesia simulation, which is also outside this auditorium. And lunch will be provided in the 4th floor.
So I request all the residents to take this opportunity. There is a robotic system placed in the Da Vinci vehicle. So you can go and get a hands-on sort of experience on that. And also there are Panther stalls where you can try and find these uniportal staplers. So you can get that. We'll be keeping them for maybe 2 hours. Post lunch, you can practice for all the trainees. So now coming to the most awaited announcement, the session for the competition. I think our judges have prepared a list. I would like to invite first Dr. Sushma and Dr. Madhav to come over the dais. So we have 3 winners here in the competition session. Unfortunately, last 3 presentations, even though they were really good, they could not be included for the competition session because of some technical issue yesterday. So here we have 3 awardees. So the first prize, we have double scoring done. I think most of the abstracts were scored yesterday by a set of judges, independent judges. Again, today we had a second set of judges who shortlisted 3 best papers. All right. So the third prize, we'll start from third prize, goes to Dr. Neha Telikeri from AIMS Jodhpur. Let's give her a big hand. Then the second prize goes to Dr. Pawan Kumar from AIMS Bhubaneswar. We are seeing budding thoracic surgeons now. And the first prize goes to Dr. Shivani Kapila from AIMS New Delhi. Shivani. Thank you. Thank you, Dr. Sushman. Thank you, Mother. Now, I think we will conclude the session here. We had a formal vote of thanks yesterday, but I would like to thank everyone, the entire organizing committee, NCI administration, all the delegates, faculty, sponsors, all support staff. So without which this event would not have been possible. I'm sure you all have got money's worth. This kind of courses will cost you anywhere between 8 to 10 lakhs if you go to a European country or North America. So that's what we are trying to do more these kind of courses, hands-on courses, focused courses on these kind of technologies, so that most of the budding or mid-level Indian surgeons can benefit. I'm sure you got. We would like to have your feedback. Be in touch with the organizing team if you have any suggestions, because we are planning to fix the next course date also for the same VATS sometime in February 24. So we would like to have your feedbacks, any modifications or any change in the structure of the program are welcome. Please be in touch with Dr. Sunil and Dr. Naveen. So with that, I would like to conclude the conference. Thank you very much. Thank you for your active participation. Thank you. Are you going to play some national anthem? Yeah, please.
One more announcement. Stapler practices can be done at the Panther stall, which is outside.
डिजिटल इंडिया पहल के तहत
Please rise for national anthem. Thank you. Please everyone join us for lunch. Bus services starts at 2 p.m. from H3 apartment, which goes through airport to Delhi.
All of the delegates can take advantage of the hands-on labs which have been prepared, both for anesthesia as well as VAT simulator, stapler practice at the Panther Company stall outside, and robotic Da Vinci simulation outside the building. Thank you.
एम्स नई दिल्ली का राष्ट्रीय कैंसर संस्थान झज्जर भारत का सबसे बड़ा कैंसर चिकित्सा, शिक्षा एवं अनुसंधान केंद्र है। एनसीआई में वार्षिक 5 लाख रोगियों के उपचार के लिए 710 बेड का प्रबंध होगा। 25 आधुनिक मॉड्यूलर ऑपरेशन थिएटर से लैस एनसीआई देश का पहला सरकारी अस्पताल है, जिसमें लीनियर एक्सेलरेटर के अलावा प्रोटॉन चिकित्सा की भी सुविधा होगी। यहाँ 15 करोड़ की लागत से पूर्ण रोबोटिक लैब स्थापित की गई है, जिसमें प्रतिदिन 60,000 से अधिक टेस्ट किए जा सकते हैं। भारत सरकार की डिजिटल इंडिया पहल के तहत पेपरलेस क्रिटिकल केयर सिस्टम एवं ओटी इंटीग्रेशन की सुविधा भी स्थापित की गई है। एनसीआई में 700 करोड़ से अधिक के आधुनिक चिकित्सा उपकरण स्थापित किए जा रहे हैं, जिनके माध्यम से व्यापक कैंसर चिकित्सा, शिक्षा एवं अनुसंधान किया जाएगा।
देखो इन्हें ये है ओस की बूंदे, पत्तों की गोद में आसमां से कूदे, अंगड़ाई ले फिर करवट बदल कर, नाजुक से मोती हंस दे फिसल कर, खो न जाए ये तारे ज़मीं पर। ये तो है सर्दी में धूप की किरणें, उतरे जो आंगन को सुनहरा सा करने, मन के अंधेरों को रोशन सा कर दे, ठिठुरती हथेली की रंगत बदल दे, खो न जाए ये तारे जमीन पर।
छोड़ देते हैं, हम छोड़ देते क्यों आपको क्यों तंग करना, हमें पसंद नहीं है आपको अच्छे करने के लिए ना ये सब
जैसे रंगों भरी पिचकारी, जैसे तितलियां फूलों की क्यारी।